So good evening, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare. Welcome you all for today's webinar. So World Cancer Day is marked on 4th February to raise awareness of cancer and to encourage its prevention, detection, and treatment. So today we have Oxy joining hands with TASO, that is Tamil Nadu Association of Surgical Oncologists, on this World Cancer Day. And I would like to welcome the president of both societies, that Dr. Jairani Kamaraj ma'am, President Oxy, Dr. Kundavi Shankar, Secretary Oxy, and Dr. Suresh Venkatachalam sir, President TASO, and Dr. S. Ayappan, Secretary TASO. So I'd like to welcome all the moderators, chairpersons, speakers, panelists, and delegates who has joined for today's session. Welcome you all, and I'm under the session for the members to take over. Welcome.
Thank you so much. A great evening to all of you. 4th February marks the World Cancer Day, and Oxy today has joined hands with the prestigious TASO, the Tamil Nadu Association of Surgical Oncologists, to conduct a focused webinar on managing early uterine cancer. Can we have the next slide, please? Chitrakala, next slide, please. Please change the slide. Can we have the CV? Our vibrant president...
Sumati, just keep going.
Yeah, our vibrant president of Oxy, Dr. Jairani Kamaraj, is a senior consultant of reproductive medicine and is a director of Akash Fertility Center and Hospital, Chennai. She's the treasurer of TAPIZAR and an associate secretary and advisory council member of World Association of Sexual Health. She is a member of many prestigious societies and at national and international arena, and has many medals and awards to her credit. And we have our next slide, please. Our honorary secretary of Oxy, Dr. Kundavi Shankar. She is a lead fertility consultant of IRM MMM. She is an active member of many prestigious societies, and she is an endometriosis committee member and runs a very successful fellowship program in IRM MMM and has many publications to her credit. I now request Oxy president to deliver the welcome address.
Anevarukkum Malai Vanakkam. Thank you, Sumati, for the nice introduction. And I have the great pleasure, pride, and honor to join hands with the Tamil Nadu Association of Surgical Oncologists, which is a great pleasure for Oxy, to welcome all the senior faculties of both fraternities of the surgical oncologist as well as the OBGYN team for this wonderful webinar to create an awareness of the early management of the uterine cancer, which is a real need of the hour of many of the OBGYNs as well as the oncologists here. So we all know since 2000, we have been celebrating this day, this 4th February as the World Cancer Day, and every day we are improving in the care for the cancer patient. And we have a lot of vision to create a lot of awareness among the public that what was previously thought as a problem which cannot be cured, but now with the inventions, interventions, and increasing over scientific treatment modalities, we have come to a point that this cancer can be cured. And I think this is a vision that we all have and hope to completely cure the cancer. And we as a team work together to achieve this and to create that achievement and to make an awareness among the public and create an awareness that this can be corrected and this can be curable, which is a very important thing that we want to convey to the public, and to create that awareness among our faculties to improve in their knowledge of the care to be given to the patient. We need a lot of forum like this to work together. So in this content, I have the great pride to be here that we always have the theme we know that close the care gap, which is a very important theme of this year, that we always come together to close the gap among the treatment as well as all the treatment and care to be given to the patients who are affected with the cancer, which is a very important one that we all should do at this day from this juncture to create an awareness and improve the knowledge and awareness about the treatment modalities. And we have here with us the great faculties from the Tamil Nadu Oncologist Association, headed by our Dr. Suresh Venkatachalam sir. We welcome you on behalf of Oxy for this wonderful webinar. And sir, being the professor and HOD of the surgical oncology of the Regional Cancer Center at Coimbatore Medical College. And he's been a member of the Association of Surgeons of India. And he was an endocrine surgeon of Indian Association member. And he's the executive member of the Tamil Nadu and Pondicherry chapter of ASI from 2010 to 12. And he's a chairman of Association of Surgeons of India between 2015 and 16, and the joint secretary of Association of Surgeons of India between 2012 and 2014. We welcome you, sir. And Oxy has a pride in welcoming you, sir. And
thank you.
And I'm happy to welcome Dr. Ayyappan, who is a young, dynamic secretary of the senior oncologist whom I know more than 25 years. And I know he has been wonderful doing a lot of work in the surgical oncology in Chennai. And he's a senior consultant academic head of the Department of DefenB program of Department of Surgical Oncology from Apollo Cancer Hospital. And he's a robotic and laparoscopic surgeon. And he's a pioneer in advanced laparoscopic gynec oncology and colorectal cancer. One of his first to perform HIPEC for advanced ovarian cancers in the country. It's a real pride. And he's a pioneer in the limb salvage surgery for extremities in sarcoma patients. And that is a real amazing achievement. And he has a lot of academic contributions by publication and by faculty presence. And he is a present examiner for many of the DefenB exams. We welcome you, sir, Dr. Ayyappan, for this webinar. And I have a very great pride to say my team, who is headed by the Sumati, 2 weeks. I know you don't need any introduction, Sumati. We are the director. She's the director of the Darshan Fertility and Women's Medical Center in Chennai, and she's our present executive committee member, Oxy. And she's the coordinator for the Public Awareness Committee of Foxy. And she's the master trainer of the VIRA, and No to Violence Against Women of Foxy. And she's a co-chair of the Women's Doctor Wings of the IMA. And she's a state council member of IMA. And she, along with Ayyappan, is coordinating this wonderful webinar over the past 2 weeks in a wonderful way. And I thank you, Sumati and Ayyappan, for coordinating this. And I welcome all the senior faculties of both the specialities, and also welcome all the delegates who have logged in for this wonderful webinar. A very special thanks to Shield for organizing this platform for this wonderful webinar. And on behalf of Oxy, I welcome you one and all, and over to Sumati and Ayyappan for the further proceeding.
Thank you, madam. Can we have the next slide, please? We now go on for the Oxy prayer. Thank you, God. In humility we gather. In gratitude we pray for all the things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you all. I now request Dr. Ayyappan to carry on the proceedings.
Thank you, my dear friends. Thank you for those sweet introductions which you have done for all of us. Madam has taken the job of introducing all of us. Can I have the next slide? Now I am going to have the privilege of introducing the chairpersons. And I take great privilege and honor in introducing my fellow guy, who is Professor Dr. S. Rajasundaram. He is a director as of now for the Nichols Global Cancer Center, director of Sundaram Cancer Center, Kilpak, and is the head surgical oncology and the convener for South Global Oncology. I welcome you, Dr. Rajasundaram. And Sumati, why don't you, and Prashant, a very close friend of mine. He is an additional professor and head department of surgical oncology in JIPMER. His special interest is in thoracic oncology and head and neck oncology, though he is taking care of a lot of gynae patients. And as you see, the peritone surface malignancy, which is catching up very fast, and he's doing a lot of robotic surgeries. He's got a lot of publications, and he's got a gold medal in MCH surgical oncology, a very coveted one, and the best MCH student. Good, very good membership and fellowship for various other things. I welcome you both for this thing, and all the best for the whole program. Dr. Sumati?
Yeah.
Yes.
We welcome Dr. Vijaya. She is the professor of Department of Obstetrics and Gynecology, Sri Balaji Medical College and Hospital, Chennai. She's a former director of IOG, Madras Medical College, Chennai. And she is the present vice president of Oxy. She has plenty of credits. She did a lot of things during the COVID period in the IOG. And she's a national level master trainer skill lab and national level master trainer in safe delivery practices, and is a state level master trainer in EMONC, and is a state level master trainer in cervical cancer screening and colposcopy. And she has been the UG and PG examiner in Tamil Nadu, Karnataka and Kerala. Many awards to her credit, many publications to credit. Welcome you, ma'am. This forum is now filled with a lot of nice people. And I'll welcome Dr. Geeta Lakshmi, who is a senior consultant and registrar of Department of Obstetrics and Gynecology, KGH, Madras Medical College. And she is a UG and PG examiner. And she has been there as a teacher for the past 22 years. She is our, okay, I think there is a small change there. She's our joint secretary of Oxy, and she's a member of Chennai Menopausal Society and ISOPAP. Thank you, Dr. Geeta Lakshmi, for joining. And I request the chairpersons now to introduce the speakers. The first speaker, please. Is Dr. Raja Sundaram here to introduce?
Good evening, everyone. Thank you, Dr. Sumati, Dr. Ayyappan, for organizing this wonderful event for next 2 hours. And I'm really honored to introduce my good friend, Dr. Bhargavi Karthikesh from Ramakrishna Cancer Center. She's a senior surgical oncologist from Ramakrishna Hospital, was a junior in Cancer Institute. And she did her MBBS from Cupak Medical College, MS from Madras Medical College, MCH Cancer Institute, and FRCS in 1999. She's assistant professor of Department of Surgical Oncology, Cancer Institute, and now she is doing extremely good work at Ramakrishna Hospital along with Karthikesh, and for the past 20 years, I think. I think she'll deliver an excellent lecture on recent advances in endometrial cancer.
Thank you so much, sir.
Yes, but
Just trying to get my slides through. Are my slides seen, sir?
Yes.
yes.
First of all, I would thank Dr. Ayyappan, who's been my faculty in Cancer Institute, for his immense trust and confidence on me that I would do justice to the topic. Because there are so many surgical oncologists who passed out of institute and whom we might know really. Thank you, sir, for this wonderful opportunity. Because, you know, it's always been for an oncologist, not only for an oncologist, for any medical person to be constantly updating, which is very, very important. And so, you know, it really gives us a privilege to share the little knowledge that we have. And Raja Sundaram, sir, my senior at Adyar, and we know each other too well. And it's a privilege for me to have got introduced by you. Really, thank you, sir. Thank you so much for your nice words. And going to the topic, the thing is, recent advances in early endometrial cancer. I think Ayyappan sir and his wonderful team of gynecologists have chosen the topic right, because always in cancer, when we look at treatment, we always look at trying to do lesser and lesser. That is how the evolution of cancer treatment has been. That is, you look for smaller, finer points and treat, and try to do lesser and lesser mutilating surgeries, or lesser and lesser morbidity producing surgeries. Coming to that, it is always wise to choose cancers which are early, because they are the ones which will be amenable for all these things. Yes. And the thing is, in recent advance on early endometrial cancer, early means it's just stage 1 and 2. That's what we are looking at. And why? It's not just that the treatment or the investigative modes that have changed. It's also that right from the epidemiology, there are changing trends. that is the incidence by the American Cancer Society's 2022 update. It says that the younger age groups are getting affected more, while in the years it used to be, over 60 is what they will get affected with cancer. But while now we find even the 30s and the 40s getting affected with cancer, as we would see later, that is why the classification of a type 1 and type 2 endometrial cancers have come into. That's about the age at incidence. And not only that, the overall incidence has also been going up, as seen by the US data, where, year to year, there is a 2% increase in the incidence. Why are we alarmed by this increase in the incidence? There is 1/3 mortality. So that is the thing why it's that we have to be aware of it. And histological type wise, while over 60 is usually, the bad variety is found more commonly, while we find in the younger age groups which are getting affected, we find more of the good variety. I'm so sorry. Okay, coming to the etiology, obesity has taken up as one of the, as we know, it has been all through that obesity is a high risk factor for endometrial cancer. It is more so now because the younger age groups, the type 1s, which are getting affected with endometrial cancer, obesity is the main etiological factor because of the peripheral conversion of androstenedione into estrogen and kind of things. So, but in the older age group, that is the type 2 ones, they might be thin, still might be affected with endometrial cancer. So the orientation towards obesity linked with early endometrial cancer in younger age groups has to be in the mind. And estrogen only hormone therapy, I'm very sure hormone replacement with only estrogen, all of us are becoming wary of it because progestins protect and estrogens promote. The same thing with tamoxifen. When in the old age groups, if we keep using tamoxifen over 5 years, there is upregulation of the estrogenic receptors because tamoxifen is a competitive inhibitor for estrogen. It's a partial agonist antagonist. And so the estrogenic effect becomes more when it is used. That is, the incidence of cancer, the endometrial cancer goes up by even 4 times. And why I've added about Lynch syndrome is, most of the endometrial cancers are all, they are sporadic, but still that 9 to 10% which are having this hereditary etiology, most of them have Lynch. 90% of the hereditary cancers are Lynch. And whenever we find this mismatch repair, see, the study of mutations, which was only in the books, is coming into practice now. And so all of us should be aware of things. And so Lynch syndrome is being considered to be one of the major etiological factors because 40 to 60% of the ones with the MSH1 mutations, they have endometrial cancer. And most of them can be caught early as well. Cowden's is the other one where we have breast and thyroid coexisting. And coming to the symptoms, the age-old symptom of postmenopausal bleed, 80 to 90% of the endometrial cancers present with postmenopausal bleed, while only 10 to 15% of the postmenopausal bleeds are endometrial cancers. I just wanted to highlight on this because any postmenopausal bleed has to have an endometrial biopsy. Of late, it is usually curettage in the office. Whenever you find an os that is open enough, you can just get in a pickles for a biopsy, and that is the People's curette, which is sent inside, and then you withdraw the plunger, and then the material gets stuck after you hit the fundus. There's an office procedure, patient walks away, and the sensitivity is to the extent of 95% and specificity to the extent of 99%. It falls a little bit in the premenopausals. If not, what next? There is a very high suspicion of malignancy, but we are not able to get by the office endometrial biopsy. Then we have to go in for a dilatation and curettage. Or if the symptom is keeping on persisting, then we have to go in for a dilatation and curettage. Fertility preservation when it is being planned, again, we have to be guarded about it because patients, young patients, when they come in with their type 1 endometrial CA early, then we have to think about fertility preservation by way of, treating them with progestins. That time we have to have a dilatation and curettage and a proper biopsy. Going to the imaging, the thickness of endometrium as decided by the Society of Radiologists consensus in 2001 has been a 5 mm or more. And that is a picture just to show that. Again, going to the, you might wonder what all these are about in the recent advances. I just wanted to recapitulate a few things so that our index of suspicion will be kept up so that we can catch more early endometrial cancers early. CT scan has its own gross limitations regarding the primary disease. It might be helpful because many of us still ask for a contrast enhanced CT, but it is predominantly useful only for the extrauterine disease. And extrauterine disease, and hence the high-risk groups, because more high-risk groups of the serous or the clear cell variants, they have distant disease or paraiotic nodes, and so it will be useful. The say of today in a difficult setup is a transvaginal ultrasound. If not, MRI with dynamic contrast is the say. So it helps us in a lot of ways that you can even have a treatment staging with depth of infiltration regarding the myometrium as well as the infiltration of cervix, because cervical endocervical glandular involvement no longer is in the staging. So we need to have a definite idea about the involvement of the cervical stroma, because if the cervical stroma is involved, we need to do a radical hysterectomy. If not, we can stay away with just a simple hysterectomy. So those are just pictures of our MRIs. Yes. The other word about CA125, it has been studied in the Korean gynec-oncology group, where they have taken CA125 along with the MRI findings, age and of the patient, just to, they have developed a marker to say that CA125 has been one of the indicators when it is above 35 milli-international units. It is international units per ml. It is of significant value. The other value of CA125 in endometrial cancer is, if at all it is elevated initially, and it helps us to monitor the tumor response. And if so, it helps in the, if pre-treatment elevation has been there, then post-treatment surveillance is possible with it. And so much so about the investigational modalities. Now that we have the biopsy, what do we look for? When we look for in the biopsy, we have to look for whether it is hyperplasia or it is malignancy. If it is hyperplasia, we have to look for simple and complex. Why do we have to differentiate simple and complexes? Simple hyperplasia has lesser chance for having atypia along with it. That is, 1 to 2% of simple hyperplasias may have. Simple hyperplasias, you don't find much branching of the glands, and they are all typically preserved, except that the cells are proliferated. So simple hyperplasia is less often associated with atypia, while complex atypia is complex hyperplasia is more often, that is about 30% of the time it is associated with hyperplasia. Why are we with atypia? I'm sorry, complex hyperplasia, 30% of the time is associated with atypia. Why do we really have to bother about it? Because any atypia has a 40% incidence of concurrent invasive carcinoma. And all this while we were thinking and talking about this type 1 and type 2, that is a cumbersome slide, but it does carry a lot of meaning, because the type 1s are really the low grade ones. They are endometrioid type, and metastasis is very uncommon, prognosis is extremely good. And as we come to the molecular markers, we will find that they are very low proliferative potential. So Ki67 is low. But more often than not, we will not be looking for Ki67 in endometrium as far as we look in breast. But we do have to look for the MMR loss. We will see next, though all this is only in evolution, we have to keep looking for them. Only then will we evolve and try and do more and more for better and better survivals. While the type 2 are the ones which are high-grade endometrioid serous of the clear cell, and where you find a chance for metastasis to the lymph nodes, peritoneum, as well as distant organs. with aberrant P53, which is one of the very, very bad markers, will be present. That is, in short, the genetic basis for this type 1, type 2. Type 1 are those patients, the obese patients, young patients, who constitute 70 to 80% with KRAS mutation and PTEN mutation loss, and they have this mismatch repair gene mutation leading on to microsatellite instability. And they are the ones in whom you do have only in advanced diseases, the immunotherapy being available against all these antigens if they are present. Type 2 are the ones, the older patients, and who often have an advanced stage of disease and the serous or the clear cell varieties, and they have aneuploidy and a P53 aberrant mutation or HER2/neu overexpression. These are the ones which are the bad group. Going to the prognostic factors, we know that staging is the one. And in staging of late, we know that stage 1 and 2, the difference is made only based on the cervical stromal involvement, and endocervical glandular involvement is still not as bad as the stage 2. And age, grade, race, histologic type, and LVI, all these, we cannot say that they are strictly independent prognostic factors, because older age patients have a higher grade tumor, and a higher grade tumor present late, so the stage will be late. The blacks, they might be presenting with a higher grade tumor, and so they will be having a bad prognosis. So they are all interlinked. All that we know is that is because there's been no study which could really, put all these things together separately. Though this LVI, the lymphovascular invasion, and age are strict factors which we will see later in the NCCN guidelines also for treatment purposes, because in the absence of lymphovascular invasion, the nodal metastasis rates are very low. So, the treatment of the nodes can be even more conservative in the absence of LVI. So this is a small thing about the upcoming trends, where we find that the Cancer Genomic Atlas subgroup, they took 100 cases and they looked for the mutations. The pole mutations, which constitute only the 5%, are the best ones to have. Pole is polymerase epsilon. That the mutation, if it is present, the patients do well. Okay, maybe over the period of years, if you had a patient, young patient, a type 1 with a pole mutation, we can just observe them. Okay, while if they had a copy number high, that is the mutant P53, they are going to be aggressive, and we have to treat them aggressively using even agents that will act against the P53 mutant gene. Okay, so the copy number low is the wild type P53, which when present, the patients do better than the copy number high, but it's not as good as a pole mutation or an MSI. So that is about there have been multiple groups which have been trying to work out nomograms using even these. And one of the POTEC has been the post-operative radiotherapy for endometrial cancer. There's a group which has been, taking up even the mutations into consideration and classifying patients, while PROMISE is the other one that has, come up. All these are just to say that when you PROMISE has gone to the extent that when you take a sample of the endometrium for a biopsy, you do look for MMR mutation on the IHC. Okay, if that is excluded, they look for the pole. So they have the algorithm developed in order to make sure that, we really strike at the right point so that the immunotherapy can be implemented to make the patients get benefited better. So this is the purpose. See, if the pole is ultra mutated, then, or the microsatellite instability because of the MMR, the mismatch repair gene mutation is there, then patients have adaptive immune resistance, and so they respond to treatment with anti-PDI. See, as PD-1, as of now, these drugs are being used only for advanced cancers. Soon we might have a time when these will be used as even adjuvants. isn't it? So the low copy number behaves in between the pole mutation and the high copy number, which is the serous-like. And so they have immunoignorance. And so where, you have to do a mix and match of everything together. You use chemotherapy, you use radiotherapy, you use immunotherapy. Okay, you try and mix and match because they are the bad variants. And so all kinds of treatment will be useful. So the recent advance in endometrial cancer staging as compared to the previous figure is, as I said already, the endocervical glands, and peritoneal cytology is no longer into any bit of the staging because, peritoneal cytology happens more often with serous, papillary serous, or a clear cell or an undifferentiated histology. And so it is not a separate prognostic indicator. And parametrial involvement is 3B. And the important point to make is in the 3C1 and C2, that is the nodal disease, the pelvic and the paraiotic nodes, where you find that macroscopic metastasis is more than 2 millimeter micro. Why do we have to know this? Because there is still a chance that the ITCs, that is the isolated tumor cells, that is where you find 0.2 millimeter and lesser sized deposits, which have or lesser than 200 cells. Okay, so they can be treated with a more conservative approach rather than the micro or the macro positivity, where you might be giving them pelvic CAR-T. The norm has been a simple hysterectomy with BSO and a lymph node assessment. Why a BSO? It has already been like the norm of the treatment of endometrial cancer because of the involvement of synchronous involvement of the ovary or deposits into it, which can be about 8 to 10%. So the GOG trial, as all of us know, which was published in JCO in 2009, says that LAP is as good as open surgery in the terms of survival, in terms of cancer treatment. But the morbidity is definitely lesser by way of the hospital stay, and there is no change in the survival. And so, as of now, LAP surgery for an early endometrial cancer still holds as almost the gold standard. In the presence of robo, if it is possible for a robotic surgery and logistics permit, then robotic still also has a say. Lymph node assessment. Earlier, it used to be a definite pelvic node dissection, but no longer, because of the morbidity involved in the lymph node dissection, which by way of lymphocele or lymphedema of the legs. Lymphoceles are sometimes a real pain to treat when you may have to even, pigtail it, or they might get infected, and sometimes you have to get in a lab to drain it out. So given all that, do all these patients of early endometrial cancer need such procedures? So that is when things came up that suspicious lymph nodes can only be taken off. But that doesn't really buy well to the oncologist's mind. And so now is striking a via media between a sentinel lymph node mapping rather than a lymphadenectomy. Pelvic lymph nodes. See, the retroperitoneal lymph nodes are not routinely dissected. It is dissected only in the high-grade variants, or when we have a gross, more than 50% or outer myometrial invasion is present, because even if pelvic nodes are not positive, paraiotic nodes are going to be positive only 4% of the times. And early in the disease, we will find that the pelvic nodal positivity itself is around only 30%, 20 to 30%. If it is going to be a stage 1A, it is less than 10%. So given that fact, so why do we have to go in for a retroperitoneal lymphadenectomy unnecessarily? Because it doesn't change the survival either. So there is no improvement in overall survival due to lymphadenectomy in stage 1 low grade. But stage 1 high grade, still there is guarded prognosis. MSKCC still feels that stage 1A a grade 3 can still go in for a sentinel lymph node. While, world over, it has been accepted that stage 1A, grade 1 and 2, sentinel lymph node mapping might be adequate, because successful mapping is usually achieved in around 50%, and the other 50%, whenever it is not mapped, that site has to be, whether it is unilateral or bilateral, wherever the mapping is not done, that has to be dissected. The sensitivity is quite high, around 95%. The best thing about sentinel lymph node mapping in endometrium that's really coming up in a very big way is, we are yet to start it, is the negative predictive value of 99%. That is, if it is negative, it is negative definitely. And so it is so much investigation which will save the patient the problems of a lymphadenectomy. So missing the isolated para-aortic nodes, it really doesn't convert into much of, as I said, it's not that, you go in and take the nodes in the para-aortic region. In the absence of pelvic nodes, it's going to be positive. It is only going to be positive 4% of the times. And there's one thing very nice about the sentinel lymph node mapping is, more positive nodes are got compared to even lymphadenectomy. Isn't that ironical? So, and this presence of para-aortic nodes, 4% of the times, when you will miss out if you didn't dissect it routinely, is not going to really convert into survival rates, or a relapse-free survival, or disease-free survival, or an overall survival. Because whenever these patients fail in the para-aortic region, they appear to be failing in the other regions also. So in which case, it's not really going to add. So a stage 1A and a grade 1 and 2 sentinel lymph node biopsy might be the same. As I said, MSKCC still believes in, even in a high grade, a stage 1, a sentinel lymph node biopsy is a possibility. And going to the POTEC trials, which have really made a mark in the lymph node dissections. The POTEC one, which started its approval in 1990 and finished it in 1997, it compared the pelvic external beam RT to no additional treatment, that is after the nodal dissection, plus minus a nodal dissection in early endometrial cancers. It showed that what they did is, they had an arm for vaginal brachy and the other arm for external RT, a pelvic RT. Local control was better, but without a survival advantage. So why do we have to again think about a brachy versus an external RT? Is the one is the recurrence rates. The other thing is the bowel morbidity is much more with a pelvic RT. So pelvic external RT for endometrial carcinoma is associated with a long-term urinary and bowel symptoms, leading to low physical functioning even 15 years after treatment. So EBRT is justified only for patients at relatively high risk for recurrence. Who are these ones at high risk for recurrence? They are either 1B disease with more than 50% myometrial invasion, or a grade 3 disease, that is 1B, grade 1, 2, or they are a grade 3 disease. It can be a 1A or 1B grade 3 disease, or a grade stage 2 disease, or grade 1, grade 1A, stage 1A with grade 1 and 2, but their age is a factor, more than 60 years, then they have to have, or with an LVI, then they go in for external beam RT. Vaginal brachy versus pelvic RT was addressed in POTEC 2, and they found that there is no significant difference in vaginal recurrence, but there was more pelvic recurrence with vaginal brachytherapy than with EBRT, but it didn't convert into any bit of survival benefit. It was not converted into any overall survival benefit. And POTEC 3 has been discussing the chemoradiotherapy versus radiotherapy alone. Predominantly, the problem with POTEC 3 is it has a heterogeneous group. it has stage 3 disease as well as stage 1 and 2, which is high risk. Okay, so the absolute benefit towards chemoradiotherapy in this trial is predominantly towards that of the stage 3 disease, but still a stage 2 disease with high risk, as GOG put it, the high intermediate risk, where you find a higher grade of tumor, the age of the patient is more than 60, and you also have a LVI. All these are patients who would need a treatment with chemoradiotherapy, because all serous papillaries, clear cells, they all need definite chemoradiotherapy. The thing is, in stage 1B, grade 3, stage 1A, 1B, grade 3s versus that of papillary serous and the clear cell, when it was looked apart, definitely papillary serous, undifferentiated, and clear cell were of a poorer prognosis by way of peritoneal recurrence and distant metastasis compared to even grade 3 endometrioid of the stage 1 and 2 disease. And that is to concisely tell the NCCN guidelines, where stage 1A, grade 1 and 2, see, grade 1 and 2 observation can still be done, or if we found a LVI or the age is more, then we have to treat with a vaginal brachy. Grade 3, vaginal brachy is preferred. But as I said, MSKCC still has one small group where they would want to keep them on observation. They would even do only a sentinel node on them. Okay, but predominantly it's vaginal brachy, or if there are bad indicators like the LVSI and the age is more, we have to treat them with an EBRT. 1B disease, grade 1, vaginal brachy, but again, there is a small consideration that they can be kept under observation if the high risk factors are not there. That is the age and the lymphovascular invasion. Grade 2, again, we have vaginal brachy, which is done. And if they have bad indicators, then they also go for the EBRT. Grade, the problem is, see, the considered observation is left to the treating personnel's discretion. If it is only one focus of disease, I think we should give them the benefit of not treating them, because over-treating leads to more and more of complications is what we are bothered about nowadays. Grade 3 will definitely have 1B disease. Anything above 1A and a grade 3, they have to have, they fall into the category 2B, and so they will have radiation plus minus systemic therapy. Systemic therapy is advocated in the cases of serous and serous papillary undifferentiated or a clear cell variant. So, stage 2 disease, any grade, EBRT is done plus minus a systemic therapy. So PORTEC 4 has already started its accrual, and it's a Dutch gynec-oncology group. And the comparison is again between brachytherapy versus observation. So in order to, fine-tune the treatment to even avoiding an adjuvant vaginal brachy, the trial is on. And a touch on these molecular targeted therapies, we find that the VGA, see, we have all these, and it's not that all the tumors are going to have all of them. And targeted therapies as of now are being used only for advanced diseases, as stage 3 and more. And maybe, over a period of time, all these can be coming into play as even adjuvants. Thank you for your patient hearing, and I hope I've stuck to time and not bored you all too much. Waiting for your feedbacks.
There's one question, ma'am.
That is, yes, Dr. Sumati.
So there's one in the question answer box.
Yeah. Thanks, Bhargavi. It's wonderful, a very informative lecture.
Thank you, sir.
Of both regular format as well as recent advances. There is one question, I mean, two questions from Dr. Mohan Raj. So what is the sequence of doing mutation studies all in one go or one by one? Which one first?
Yeah, the problem is mutational analysis is all expensive and it's all time consuming also. You go for all one go, you might even, you might only incur more of, expenditure. The problem is why they have sequenced this is according to the way it can be treated and its incidence and its, see, if you found a pole mutation in the first go, you needn't have to go in for the rest because pole means that you have a good variety to treat and you are only going to keep them on follow. If at all, it's going to be a stage 1A and a grade 1 or 2. So why in that case do you need to do a mismatch repair? Why in that case do you have to look for a P53 at all? Okay, that's the reason that we have to sequence them. And again, according to the incidence that you find them. If you found a high-grade tumor, maybe you can directly go in for a P53, where you would be interested in using the immunotherapy more. See, the sequencing again is in the fact that you want to use less and less of the treatment, isn't it? So pole positive or MMR positive, the same thing, the same sequencing helps you to know that if some marker is positive, you treat that early, you need have to look for the others.
Yeah, I agree with you. The pole positive patients may not be tested for any more mutation analysis. They're one of the best prognostic group.
Yeah.
The second question is stage from Dr. Mohan Raj, stage 1A grade 3, pole mutated. What is the role of adjuvant therapy?
Yeah, you needn't have looked for the pole in that patient at all. Stage 1 grade 3 is a high grade tumor. You have to treat those patients.
There's one more question in the chat
Yeah,
box.
there's one more question. Whether SLNB.
So you're muted. So you're muted, can't hear you.
One second. Am I audible now?
Yes.
Yeah, there's a question from Dr. Shivakumar Mahalingam. SLNB, whether you do only blue dye or a dual technique.
Yeah, actually blue dye is not supposed to be so good. Indocyanine green is the best, they say. I'm really sorry that we are only doing SLNB we are going to start doing for endometrium. Thanks to Ipan sir. Now I've got motivated to do SLNB for the endometrium. Blue dye is supposed to be inferior compared to the colloid as well as the ICG.
Yeah, ideal will be ICG. ICG gives best visualization,
Yes.
especially when you do laparoscopic or robotic, you get a good vision of the node and you can do frozen, and then if it is negative, you take it as negative.
Yeah.
There is,
Yeah. Question from Dr. Vijaya, sir.
I'm not able to see it.
That's in the chat
That
box.
will be in the chat box.
Oh,
See, one more thing to add on to this scintillant node, as Raja was telling, when you put this blue dye, there is a problem during the time of dissection. So you're not able to get the planes properly. But that because the whole planes between the uterus, that is the vaginal area, and the bladder, it all gets merged. So you're not able to get the planes adequate. If you inject properly on the cervix, then it's a different story. Many a time it gets erased from the cervix and it goes in the space and it becomes a problem. ICG is excellent.
Yeah, with the advent of ICG, I think ICG scores over all the other modalities.
Yeah.
And very cost effective. Very, very cost effective.
Yeah.
And one more question is, how do we know the grade intraoperatively? Should we do frozen?
No, the grade is usually known when you have a pre-therapy biopsy.
Preoperative.
So you do either a PIPL or a dilatation curettage and you have the grade with us. So because high grades generally are not missed. Okay, all that we want to rule out is a high grade disease. You consider it as low grade and treat.
If adding on to it, for cancer endometrium, we hardly do frozen section on table for making a diagnosis or for making a staging, whatever it is. So it's all done pre-operatively and then treatment is planned very well on the table.
because endometrium is a large area for biopsying. So the pathologist will find it very difficult to, because if you had only one focus which is looking aberrant, abnormal, they might biopsy that for frozen. But most of the time you will find that the thickness of the endometrium is most of the cavity. So in which case, biopsying by frozen will be difficult, and which means that we will lose the sensitivity of the test. We might miss out on foci. So generally it is a preoperative diagnosis.
Yeah, no pathologist will have to do a frozen on endometrium. I
Sir,
mean,
one
if
more
it is the
question,
entire
sir.
uterus for frozen. Yeah. One
No,
more
it,
question.
it can be done. Only thing is, if we had only one abnormal, you have to section the uterus, take a look. If at all you find one abnormal focus, it's fine. But most of the time, the whole thing will be, papillary projected, and we won't know which is the, we found foci, fine. But many a time it doesn't happen.
Actually, this is going to be addressed by Guru in the next talk.
Oh,
This is a controversial
Yeah,
area.
Right.
So the next question which has been asked by Vijaya, the people showed a disorder. That is the favorite thing of Dr. Kavita in the panel discussion.
Okay. Then fine.
Yeah, Dr. Deepthi has raised her hand. Dr. Deepthi, you have anything to say?
So this is a discussion. I just want to start here. Whoever are doing sentinel lymph node biopsy, so actually what was recommended was the ultra staging, which is possible only, and the ideally should be cut in a small sizes, and then H&E section should be done. But most of us do with the frozen section, which is not actually ideal way to do it. I don't know how many of us are doing when the way it has been defined, because I do with the frozen section. So I just wanted to know the opinion of all experts here. How do you do it?
I do frozen section.
I guess most of us will be doing frozen sections here whenever we are doing, the sentinel lymph node. That is what is available to us on a practical basis, and that is what we'll do. In fact, I believe there are certain groups of people who don't even do a frozen section. It is more of an aging thing, unless there are grossly enlarged nodes which are seen on the preoperative imaging or something which you find suspicious intraoperatively. We just do it as a staging procedure to say that the nodal staging is done. What we were doing as a BPLND before, we now just do the nodes, we take it out. We don't even send an FS off late. Dr. Vijay Kumar, in fact, from Amrita, he also says the same thing. He has stopped doing frozen sections also. He just does the, nodal dissection, the sentinel lymph node technique, and that's it. And a note or two to add, since I've used both the blue dye technique and the ICG technique, both of which we use depending on the availability of the lap IR camera. Dr. Raja Sundaram said it's very cost effective. Yes, the dye itself is not very expensive, but the lab setup is needed. That is quite expensive. That is almost double the price of a regular lab camera. So that's the only point, because we need the entire setup to be separate. Unless we have the lab IR setup, the light source, everything, if it is available, then the dye is only $2,000. So that is very cheap. And as far as the dye ICG vis-a-vis comparison to methylene blue, both of them work well. One point which I would like to add, which I've had few cases where we have had some problem is when we inject the blue dye at times, especially in patients who have a kind of like an atrophic uterus, a very small one, or some cases of prolapse, the entire pelvis will get stained. That happens more often with the blue dye rather than with the ICG. That is one advantage of the ICG that we will have. So there you will not be able to see anything. Once you open up, it's not about the planes, it's about nothing being visible. Everything will be looking blue on, doing it on laparoscopy. So that is one problem which we get. And one suggestion which I take is like there is a deep, SLNB technique and a superficial SLNB technique which is recommended. I personally find that the mucosal technique, where you just go inside the mucosa of the cervix, about 2 to 3 millimeters, not beyond that, not deep inside the cervix, because previously I used to do the deep technique thinking that the rate of SLNBs will be higher, but I find personally that mucosal injection gives the best, SLNB identification rates. A few personal observations.
I think we should go to the next speaker.
Yes. In the interest of time, I think Suresh sir has raised his hand. So one last word before we go on to the next speaker.
Yeah, my question is Bhargavi.
Yes, sir.
Yeah, the thing is, 5 years back I operated endometrial carcinoma, stage 1, grade 1. I opted for observation. But what happened after 4 years, she developed local recurrence. So in spite of it is grade 1 and T1, Now the question of whether observation is, I'm really scared to rest of my patient. Should you give all patients brachytherapy? Probably that lady would have been surviving by this time. So what is your comment on this?
Yes, sir, correct. What you say is right. See, what we are trying to come to is, see, 10% of the patients can recover. Okay. So, but we can never say who's the 10%. The other problem is the grade of the disease. We should have been, is it been right is a question, because grade 1 and 2, generally they behave similar. It's only that the grade 3 behaves different. Was this a vault recurrence or a pelvic recurrence, sir?
Vault recurrence.
Vault recurrence. In which
Probably
case, we have to take with a pinch of salt whether it had been a one-year disease or not, isn't it?
Yeah.
Being
Probably that
disease,
time we didn't have all these molecular subtypes.
yes.
Probably had we that options, maybe perhaps I would have gone for a
Yes.
brachytherapy.
It's like the Oncotype DX in a CA breast.
Yeah. Nice presentation, Bhargavi.
Thank
Good.
you. Thank you, sir. Thank you so much.
Thank you. Thank you all for the wonderful
Can I
discussion.
just add one point before we close? Can I just add one point?
Yes, ma'am.
See, frozen section for the sentinel lymph nodes, why it's really going out of vogue is, see, it's not just a matter of absence of the technique or the facility in a place. It is because of very, very potential post-operative treatments that are available. See, what you're wanting to look at is the patient node positive or not, so that you can institute, adjuvant treatment. Now, maybe that is the reason that frozen section is slowly going out of vogue for even sentinel lymph nodes. Thank you.
Thank you, ma'am. Thank you very much. Can we, in the interest of time, can we move on to the next session, and we could actually continue the discussion during the panel? Now, I would like to introduce, I think the ball has been set rolling for Dr. Gurmurthy to discuss on the current controversies in the management of endometrial cancer. So he's currently assistant professor, working as assistant professor in Department of Surgical Oncology at Regional Cancer Center, Madurai Medical College. He graduated from Madurai Medical College and went on to do surgical oncology at Roy Peta Kilpauk Medical College. He also has fellowship in minimal access oncosurgery, and he's an awardee. He's a gold medal awardee in MS General Surgery as well as MCH Surgical Oncology, with his areas of interest being gynae oncology, colorectal, and breast. With this introduction, Gurmurthy, the stage is set for you, and the ball has already been set rolling. So I think, thank you very much, and the stage is all yours.
Thank you, sir. Thanks for introduction. And at the outset, I would like to thank Ayappan sir for giving me this opportunity and trusting me with this job of addressing the controversies in the early endometrial cancers. And a warm greetings to all the delegates of TASO and Oxy. Sir, am I audible?
Yes. Yes.
So most of my controversies, Madam has touched upon in the recent advances. So I would like to emphasize certain things which she had left for me to discuss. So these are the areas of
full screen, sir. Please go on slideshow and full screen.
Yeah. So these are the existing ambiguities which we still have when to suspect. How do we evaluate? What does the choice of imaging? How useful a marker would be? What is the extent of surgery? The need and extent of lymphadenectomy? Controversies with the sentinel lymph node, whether the ovaries can be preserved, and the types of adjuvants that can be used. So this ma'am has briefed, though we have several different recommendations regarding the cutoff for evaluating a postmenopausal bleeding, this consensus conference statement from the Society of Radiologists in 2001 still holds good. To consider biopsy of endometrial thickness of 5 millimeter or more would get us to a false negative rate of less than 5%. And this lower cutoff is still practiced because we could gain more patients with a lesser invasive investigations like people biopsy available. So this people biopsy is still the initial investigation of choice, as in postmenopausal women, it is almost 100% sensitive, except in some premenopausal 10% we might miss. In such patients, who continue to bleed with a negative endometrial biopsy. Those 10% of patients will be a candidate for fractional curettage. And is there a role for hysteroscopy? Yes, if polyp is missed, could not be biopsied by an office endometrial biopsy or missed by a fractional curettage, could be a candidate for hysteroscopy. And there are theoretical risk of positive peritoneal cytology being higher after a hysteroscopic biopsy of a endometrial cancer, but there is no adequate data to support this theoretical possibility. And regarding the ambiguity of imaging, there is actually no equivocality. It is unequivocally MRI holds upper hand over the CT. But in the era of PET scan, we do see patients diagnosed with endometrial cancer already having a PET scan in hand. Not just in endometrial cancer, for that matter, in many cancers. People come with PET, it is freely available in many places and it covered under schemes also. But do we need a PET for early endometrial cancer? See, and since if at all a PET could detect or rule out a regional lymph nodal metastasis, though they claim a negative predictive value of 95, so PET is not of use in early uterine cancers. And regarding CA125 as a serum marker, in advanced uterine malignancies, more than 2/3 of patients would have elevated serum CA125, and up to 1/3 of early endometrial cancers can have elevated CA125. If elevated, it correlates well with the extrauterine disease. It specifically correlates with this high-risk pathology, the LVSI, and it also parallels the clinical course of disease. So it can be used in follow-up for surveillance. A 10% of patients on surveillance can be detected with serum CA125 elevation, even if had been asymptomatic. There it has a role. And as elevated serum CA125, irrespective of the grade of the lesion, if there is a significant volume of the primary, has significantly predicted pelvic lymph node metastasis. This is one area where extrauterine disease correlates well with the serum CA125. And coming to the controversies regarding the extent of surgery, this is what we routinely do for any surgical staging of apparently uterine confined disease. We remove the uterus and extrafacial hysterectomy, both the adnexa, we address the pelvic parietic nodes, and before all, we take a peritoneal cytology. So these are the numbers which are the outcomes of the GOG 33. So for these meager numbers, do we expose all other 90% of patients to such extensive surgery? And what are the possibilities of avoiding each of these controversies? We will now discuss one by one. Peritoneal wash cytology. Up to 3.5% of stage 1 patients and 7.5% of stage 2 patients had been identified in a large multicentric retrospective data of this many odd numbers to have atypical cells in peritoneal wash cytology. Specific survival, and this was more so interestingly with early stage low risk groups rather than the high intermediate risk groups. So a positive peritoneal cytology in an early endometrial cancer in a low risk patients reflects over the increased risk of distant recurrence than for high intermediate risk groups. And more importantly, these patients who had postoperative chemotherapy had reduced rate of peritoneal recurrences in the future. So though it is not included in the staging, it should essentially be done, documented, and if needed, be subjected to systemic therapy. Next controversy would be regarding lymphadenectomy. We know it stages the disease, prognosticates, and beyond that gives some regional control, helps in planning the adjuvant therapy, yet there is no survival benefit. So when there is no survival benefit, do we expose those 90% of patients who do not have any nodal metastasis risk, and who are they whom we can avoid it? So one is, these are the three components which would predict a patient who have a lesser likelihood of nodal metastasis. One is the lower grade, and the next will be the myometrial invasion. Do we have all this data accurately pre-operatively? Unfortunately, the evidences are against this, because a pre-operative endometrial biopsy grade upstages or upgrades in 15 to 20% of patients in the definitive post-op histopathology. All the more, perioperatively, we could not accurately assess the presence or absence of a myometrial invasion, especially when the tumor is of high grade. Higher grade tumors deceive gross examination on perioperative specimens. So in that case, as already been discussed from the floor, asked from the floor, will a frozen section be useful to identify? Surprisingly, NCCN guidelines says if an expert gynec pathology invasion can be obtained, and they even recommend lymphadenectomy be avoided if myoinvasion or cervical invasion is not identified. But I don't think many of us would agree, as Bhargavi ma'am rightly said, it wouldn't be an easy process to section the entire area of interest in a frozen to give a non-table suggestion regarding this. And so do that European Society of Gynec Oncology. They concur that myometrial invasion should not be assessed by frozen section because it has got poor reproducibility when compared to the permanent sections. And just before we were discussing about several biomarkers, so they agree that the biomarker prediction, the processing would be interfered by frozen section processing of the specimen. And more interestingly, there will be a incorrect assessment or false positive LVSI in a frozen section because of artifactual displacement of the tumor cells into the vascular spaces during the frozen section processing. And the answer hence would be, though recommended through NCCN, most of us and even some Western gynec associations do not concur with usage of frozen section on making an on-table decision to rule out high-risk features. And hence comes the role of a sentinel lymph node biopsy, which, as ma'am said, upstages the disease in 10% of low risk and 15% of high risk patients. So the only controversy just has been discussed would be what is the choice of dye you use. So in the recent decade after ICG has come, I would slightly disagree with Balaji sir, because it's a one-time investment to get in near infrared camera for our laparoscopic instrument, and there are many companies which are coming with the cheaper prices. So if we could invest for ICG for one time, and it has got a wide scope of applications in the field of oncology and even outside the field of oncology. So in that case, ICG has recently emerged to be the most useful investigation. Done this entire trial using ICG, showing the sentinel lymph node identification rate of up to 86%, close to 100 negative predictive value, and a very low false negative rate. So, this 86% means that some 14% of patients we might land up with failing to identify a sentinel lymph node biopsies, where the recommendations poses a dilemma between re-injection of the cervix or reflex site-specific nodal dissections. Most institutions which do a sentinel lymph node biopsy usually land up with a reflex site-specific nodal dissection, and it's up to the discretion of the treating surgeons whether to do re-injection or not. I could not trace any evidences of percentage of identifying a node after a re-injection of cervix, and experts here can help us during the discussion. And this is what Deepthi ma'am has been talking about. Ultra staging has been widely discussed in all recommendations. See, this frozen section in sentinel lymph node, or even a permanent section for that matter later, would identify only a macrometastasis that would measure more than 2 mm, because the slices are just made up to 2 mm. Whereas in an ultra staging, micron level slicings are done, and each 5 micron loaves are subjected to 2 components, which could be a further eosin hematoxylin stain of these micron level sectioning, and then to immunohistochemistry for detecting any cytokeratin expressions. So this has found to upstage this nodal staging by 5 to 15% over a routine frozen section. But recommendations actually suggest ultra staging as a part of frozen section. Just as Deepthi ma'am rightly mentioned, it is a tedious process to make a decision just based upon the frozen section, and there is no standard protocol so far for ultra staging. They suggest a different kinds of slicing techniques, bread loafing techniques, longitudinal techniques. Some say that bread loaf sensitivity than longitudinal techniques. How many microscopic slides has to be examined? How much has to be subjected to the IHC are still like unestablished standards. So this is an area for evaluation. So why do we need an ultra staging after all is identifying a micrometastasis has shown to have a worse prognosis in terms of nodal recurrence and might choose a patient for need for adjuvant therapy, whereas isolated tumor cells so far has no evidences in prognosis affecting the prognosis of any patient. Regarding parietic nodal dissection, if a sentinel node turns out to be negative in a pelvic, then we do not do a routine parietic nodal dissection because isolated parietic nodal metastasis is very rare. But when pelvic nodes are positive, at least 50% of such patients will have a parietic nodal involvement. All the more so when the common iliac nodes are positive, up to 67% of such patients will have a parietic nodal lymph node involvement. So the controversy would be, how far do we go? Do we stop at the IMA or do we need to go up to the renal hilum? Available evidences show 63% of patients who have nodal metastasis below IMA will also have nodal metastasis above the level of IMA. So it would be based on recommendations. If we need to go for parietic nodal dissection till the renal hilum. But the controversy would be, is it worth the morbidity of erythroperitoneal lymphadenectomy? Because this does not add to the survival, but only will pick up patients who might have a 3C2 disease and qualify for an additional treatment. If at all a sentinel lymph node biopsy facility is not available, then this is what the algorithm followed at a Mayo Clinic. If a patient, after diagnosing, having a pathological diagnosis, completed the staging, look at these high-risk features: grade 3, gross extrauterine disease, deeper myometrial invasion, or if patient is having non-endometrioid histology, they would also do a nomentectomy. If none of this is present, they stratify the patient based upon the tumor size and myometrial invasion. If the tumor size is more than 2 centimeters, with any myometrial invasion, they do a bilateral pelvic lymphadenectomy, subject it to frozen section, and add up parietic nodes if it is possible. If neither of this or cervical involvement is there, they stop there. So this could be a useful algorithm in institutions which do not have a sentinel lymph node biopsy technique available, but it's worth trying to procure one and doing, because it's definitely useful to reduce the morbidity of unnecessary lymphadenectomies. Can we preserve ovaries? As the previous speaker had rightly mentioned, 10% of patients will have adnexal involvement, which would be an occult 3A disease, or 5% will have a synchronous ovarian malignancies. So that's the reason why we routinely do ovarian oophorectomies during the staging. But rest 90% of patients are unnecessarily losing their ovary, and more so in the present scenario where younger premenopausal women have increasing incidence of endometrial cancer. So the recommendation now is, in a stage 1 endometrial cancer, if the patient is less than 45 years, we have a low-grade endometrioid pre-op biopsy histology, and the myometrial invasion on imaging is less than 50%, and there is no obvious intraoperative ovarian or extrauterine disease. Preserving the ovary does not impact the cancer-specific survival or the overall survival, yet the salpinx has to be removed. But this patient should be informed that there is a 5-year risk of ovarian carcinoma in future of up to 3.1%. So this has to be discussed and individualized to the patient's requirements. In case if the patient postoperatively has an occult say it's a low-grade endometrial carcinoma in the uterus and in the ovary, was it a 3A disease or is it 2 different primaries? Who has given a consensus in 2020 regarding criteria to call it double primary? If it is a low-grade endometrioid histology and there is no or only a superficial myometrial invasion in the primary, in the absence of LVSI and in the absence of any other disease outside uterus other than the ovary, these 2 primaries can be considered as separate primaries, synchronous primaries, and those being early stage disease can be observed without any adjuvant therapy. And there comes another controversial statement from the guidelines like NCCN, which states for a stage 2 patient, total hysterectomy, which means they mean an extrafacial hysterectomy, is the standard procedure, and radical hysterectomy should only be performed if needed to obtain a negative margin most of us would be surprised to read this if because we have been taught and been practicing radical hysterectomy for any endometrial cancer involving the cervical stroma. So we went and searched the literature, could find a meta-analysis of 2866 odd patients cohort studies showing radical hysterectomy does not show significant survival benefit either in overall survival or progression-free survival versus an extrafacial hysterectomy for stage 2 endometrial cancer. And they had even balanced the confounding factor like adjuvant radiation therapy in both the groups. So I would like the experts to comment on such recommendations and clarify their views at the end of the session during the discussion, because we would take it with a pinch of salt. We would not be happy to do extrafacial type 1 hysterectomy for cervical stromal involvement. Then comes the role of adjuvant therapy, whether which RT has to be given or these points. And I would just brief the background. Pelvic EBRT, if given, is not 100% adverse effect free. More than 1/4 of patients will be experiencing some degree of radiation related adverse effects, which can have a long-term impact on the health related quality of life. And yet we know there is no proven survival benefit. So do we subject all patients at risk to radiation therapy, and how do we choose? So these risk factors ma'am has briefly, given in detailed explanation, and these are the recommendations. So you have observations versus IVRT, IVRT versus IMRT, and with or without chemotherapy. So this observation versus brachytherapy versus pelvic EBRT have been, these recommendations have evolved from the trials. I would discuss a few points which ma'am has left for me to discuss. In PORTEC 1, stage 1 diseases were randomized between observation and pelvic RT. The first primary endpoint, there was a significant difference between these two, but there was no much difference in the pelvic recurrences, and hence you were convinced that a pelvic RT decreases the 5-year vaginal recurrence rate. It also identified the patients who are at risk of developing these recurrences like age, myometrial invasion, and the grade. So if only vaginal recurrence was prevented, then why not an intravaginal RT? That was clarified in PORTEC 2, which compared IVRT and pelvic RT. Definitely IVRT had an equivalent vaginal recurrence control as the pelvic RT, but there was an increase in pelvic recurrences. Interestingly, these pelvic recurrences, isolated pelvic recurrences, there was no much difference, which means IVRT has got a good vaginal recurrence control, and there was no was there any significant difference in the overall survival or disease-free survival, which means IVRT with a favorable adverse factors would have an upper hand over the pelvic RT. This was the conclusion with PORTEC 2. Both these trials did not do lymphadenectomy in their surgical staging. Hence, radiation could have just compromised for an unaddressed lymph node. This was the argument placed forth. This was addressed first by GOG-99 trial, where all patients stage 1, stage 2 with myometrial invasion completely staged with lymphadenectomy and turned out to be node negative were subjected between observation versus pelvic radiation therapy. So even if the nodes were addressed and pelvic turned out to be negative, pelvic radiation therapy had a significant reduction in 2 years recurrence rate. As such, there was no difference in the overall survival. This also identified the high intermediate risk group. So observation versus pelvic RT, even in staged patients, RT has a role. If at all, a vaginal RT could replace in this scenario is what PORTEC 4 has to tell us once the results are out. So as of now, these are the high-risk patients, high-grade, myometrial invasion, and LVSA. If a patient is more than 70 years, any of these risk factors would put them in high intermediate risk. Less than 50 years should have all these risk factors to put them into this group. Between these two, at least 2 risk factors has to be there to consider them to be in high HR group and put them into adjuvant radiation. If IVRT scores better than EBRT in the PORTEC 4, then the whole paradigm will shift towards IVRT. Why do we prefer IVRT over pelvic RT is this 7 years analysis of PORTEC-2 has still given us this result of higher morbidity in terms of long-term bowel symptoms, diarrhea, limitation due to bowel symptoms, bowel agency, urinary agency, significantly more than patients who received an IVRT. And there can be patients whom we have an early endometrial cancer, but there is a surgical contraindications where they might not be able to have a surgical staging done due to various medical reasons. So can we give a definitive RT? Yes, we can give. In that case, if you give a EBRT or an IVRT, a controversy, recommendations say if high-grade tumor and deep myometrial invasion are there, then a combination EB and brachytherapy should be done. For selected patients with low-grade tumors, brachytherapy alone might be sufficient. Systemic therapy is part and parcel of all advanced endometrial cancers. So will it be essential for high-risk patients in early endometrial cancers? It's a category 2B recommendation from NCCN, has to be individualized to the specific patients depending on the benefit they might harvest out of chemotherapy. They recommend it for stage 1B grade 3 disease and all patients with stage 2 disease. And this does not have any survival benefit, but improves the progression-free survival. And the whole scenario might change in the future when everyone comes to get this whole sequencing and this copy number low, high sequencing. This can individualize the patient based upon their genetic risk of, molecular risk of recurrences. So this has been discussed in detail. I'm not touching upon it. And in the part of surveillance, previously vaginal cytology was routinely done as we used to do for a carcinoma cervix, but now we know stage 1 endometrial cancer have a lower risk of asymptomatic vaginal recurrence, and patients who could be diagnosed with vaginal cytology alone in surveillance would be less than 1%. So we do not use this vaginal cytologies anymore. If CA-125 is elevated preoperatively, we do it for post-operative surveillance. And patients with early endometrial cancer who die out of the disease, very rarely do they do, but if they die out of the disease, more than 50% of such patients had a preoperative elevated levels of CA-125, and their recurrences were preceded by elevated CA-125. And regarding during surveillance, can we put the patient on hormone replacement therapy for hypoestrogenism? Historically, we know that endometrial cancers are estrogen-linked malignancies. And this was tried in Women's Health Initiative, where women were subjected to estrogen alone trial and found to have an increased risk of breast cancer and cardiovascular disease, and hence the study itself was stopped. But later, the long-term follow-up of patients who had received the trial suggested that estrogen alone replacement therapy may not be as high, these risks may not be as high in younger patients, and now NCCN suggests in patients at low risk of tumor recurrence, this could be safely carried out after a 6 to 12 month waiting period if at all the patient is receiving any adjuvant treatment. So concluding, biopsy cutoff would be 5 mm with most of the consensus concurring with it. No role for PET-CT in early endometrial cancer. Fractional curettage still has a role if an endometrial biopsy fails, or if a patient is a candidate for fertility sparing treatment. Fertility sparing I'm not touching here because Kavita ma'am will be discussing in detail during the panel discussion. Serum CA-125 is still a useful modality even in early endometrial cancer. Peritoneal wash cytology impacts the prognosis. Keep doing it for early endometrial cancers. ICG should be the, has already become this imaging of choice for sentinel lymph nodes. Parietic nodal dissection is a controversy still remains whether we need to be aggressive in going beyond the IMA, and there will be a risk-based adjuvant therapy, more of a molecular risk-based in the future. Ovarian preservation and hormone replacement therapy will be individualized to the specific patients. Thank you for patient listening.
Thank you very much, Dr. Gurumurthy, for the wonderful session and covering all the controversies related to endometrial cancer. So
thank you, sir.
Yeah. So any questions? Yeah, Dr. Mohanraj has actually put up that unfortunately the peritoneal cytology has been taken out of staging, but many patients who undergo hysteroscopic biopsy has peritoneal cytology alone positive. So what's your experience on that? I mean, because is it that only those patients who have undergone hysteroscopic biopsy have a higher incidence of peritoneal cytology positive, or is it generally, does it? Yes, Dr. Gurmurthy.
Sir, we rarely do hysteroscopic biopsy. Either a people, if it failed and patient has being continuously symptomatic, most of the time the diagnosis is settled with a fraction dilatation and curettage. So this hysteroscopic biopsy, I have not personally encountered. I have done it even. Literature says there is a practical risk of increased in peritoneal cytology turning out to be positive, but there is no large data available to say if it really impacts the prognosis. People who do hysteroscopic biopsy could throw light on this.
A small thing to note, the study you put up, yes, I've gone through this. Okay, but there is also a compilation by the SEER group, okay, where they said that whenever they found this peritoneal wash positivity, there were more of the grade 3 tumors and stage 2 tumors than the stage 1 tumors.
Yes, ma'am. In those patients,
this was published in the EJSO, isn't it?
Yes, ma'am.
The European Journal of Study.
Yes, in high risk patients, that cytology positivity doesn't alter the anyway, they have the poor risk groups. In only the low risk patients where it turned out positive, those patients had a higher risk of distant recurrences.
Yeah, but that's what there has been a meta-analysis which says that whenever they found positivity, I think it's the SEER groups, okay, where they said that it's just a controversial thing about this, that whenever they found a PPC, they found that they were all stage 2 or grade 3 tumors.
I think Kavita wants to add something because she does a lot of hysteroscopy.
Okay. So Gurumurthy, 2-3 things that I'd like to tell. Number one is obviously the first line investigation, though I'll be covering that in the panel, the first line investigation is going to be a PIPL, and for a grade 3 tumor, definitely most of the times it will come out positive. The ones which come out negative on a PIPL biopsy will be the polyps, the ones associated within a polyp. Okay, and so those generally, you do not have a positive peritoneal cytology. So actually speaking, so if a PIPL is non-diagnostic and the patient has got a recurrent episode of bleeding, or if your suspicion of endometrial cancer is high and you're going to do a DNC under anesthesia, it is always safer to do a hysteroscopy, because if it is a polyp, your DNC is going to come out, there's going to be no curating, but the endometrial thickness will turn out to be 14-15 mm. Then it doesn't sound good to do another anesthesia, subject the patient to another anesthesia for a hysteroscopy. So whenever you are planning for an anesthesia, always safer to put a low pressure hysteroscope. Make sure the pressure is very low so that the tubes do not open up, less than 100. No, very low pressure, just see what's there inside. So that will solve the problem of these both. So this is number one. Second is about the question of radical hysterectomy in a stage 2 endometrial cancer. Now, see, the CA cervix, radical hysterectomy for CA cervix is not equal to radical hysterectomy for a stromal invasion for endometrial cancer, because when we are planning for a radical hysterectomy for CA cervix, we are planning it as a single modality therapy. We are not planning for an additional radiotherapy upfront. We know that we are going to stop with a surgery, and only if there are worse prognostic factors, we're going to add adjuvant RT. Whereas we know upfront, when we are dealing with a stromal invasion CA cervix, this patient already belongs to a high intermediate risk category. She's going to receive adjuvant RT in the post-op period. So we generally do not plan to combine radical hysterectomy with a whole pelvic RT. The morbidity is going to be very high. Okay, so the evidence is really good enough to say that a type 1 hysterectomy is good enough for a stage 2 endometrial cancer, with a small caveat. You should be definitely sure that it is a primary endometrial cancer and not an cervical cancer which is involving the endometrium. So when you have a growth on the cervix and it comes out as adenocarcinoma, then that is a problem. You will not know whether it is an endometrial growth which is involving the cervix or an endocervical growth which is involving the endometrium. Even with IHC, sometimes it is difficult to differentiate. Now, that is the scenario when you definitely will have to undertake the patient for a type 2 radical hysterectomy, type 3 a radical hysterectomy, because you're not sure. But if you're very sure, growth in the typical risk factors, endometrial growth, process, and only cervical stromal invasion on MRI, definitely a type 1 hysterectomy would suffice for that patient. So that is the second one. And I forgot
Third
what I
one,
wanted to.
Third one you forgot. We'll have it.
We will keep it for the panel, sir. In the interest of
Yeah, yeah.
time, we will keep
Yeah,
the
fine,
third
fine.
one for the panel, Dr. Kavita.
Thank you.
So one last question, and after this, I think we should move on to the panel in the interest of time. So as I understand the question right from Dr. Balasubramaniam, like in sentinel node biopsy, is it only pelvic nodes or do you also see para-aortic nodes too? I think probably that's what the question meant, whether you wanted, I mean, is it the commonly pelvic node or do you see beyond the pelvic nodes? Is there any possibility of having a sentinel node?
We know that
sentinel.
we know the two pathways, one along the internal ilia going and sitting onto the operator, the one moving cranially to the aortic bifurcation in the presacral area. So we, in an ICG, it will anyway light up and show where it is. And it's a straightforward thing. We go and take it and send it for, we analyze. So once ICG, we would go and take it there. It could go to inframesenteric para-aortic also.
Yeah, so I completely agree. 70 to 80% of the times, most of them are in the pelvic region.
Pelvics.
But then occasionally in about 20 to 30%, you may see common iliac or even higher group of nodes. But the challenge, as rightly mentioned in the question, is, chances of missing out if these nodes are beyond the common iliac bifurcation and up to the RM, because you wouldn't have, mobilized that area adequately. To
Yes,
actually see these, and there is a high possibility, but then you do see these in about 3 to 4% of them. Even the high para-aortic also can be possible seen at ICG. And as rightly mentioned, it will show up some color as you mobilize the bowel and keep that away.
Yes,
sir, I think there are no further questions, and I think in the interest of time, we have a lot more interesting things to come up in the panel discussion. And with this, thank you, Dr. Gurumurthy, once again for the wonderful presentation. And all the experts for putting in their thoughts. And I hand over the session to the next speaker.
Vijaya, madam.
Yeah, good evening. Am I audible?
Yes,
You're
ma'am.
echoable also, madam.
Yeah, echoing. Yeah. I think I just moved. Yeah, how is it now?
Yeah, better.
Betterment.
Yeah. I would like to introduce Kavita. She doesn't need any introduction. Anything related to cancer from IOG, from KGH, and all over Chennai, in fact, from Tamil Nadu. We just call Kavita. She's such a friendly obstetrician, gynecologist, and an oncologist, and a good friend of mine. And she's now heading the gynec-oncology unit in IOG. And welcome, Kavita. And we are expecting a very, very interesting panel and lots of doubts as usual. Over to you, Kavita.
The best introduction I have ever heard.
Thank you so much, madam. Good evening to one and all. At the outset, I'd like to thank the esteemed members of TASO and OXI for having given me this opportunity, given us all the opportunity. And thank you, Vijaya, madam, for that kind introduction. And so I think, can I share my slide? Gurumurthy, someone else to stop sharing. Okay. Vijaya ma'am, will you introduce the panelists or shall I introduce the panelists?
You introduce.
Okay. So I'd like to call upon Sridevi madam is joined, sir?
No, not yet. No. She's
Yet.
not well.
Yeah, okay. So I'd like to call upon all our esteemed panelists, Dr. Bhuvaneshwari, who's got special interest in oncofertility, uterine transplant, and stem cell robotic cells. She's an obstetrician and gynecologist, GBR Fertility Center, and she also heads the fertility unit at RELA. Next, please. Dr. Balaji Ramani, who is a senior consultant surgical oncology, MGM Cancer Institute, and his areas of interest is peritoneal surface oncology and HIPEC, gynae oncology, and he is also a minimally invasive surgeon, and he's got several gold medals and awards to his credit. Next slide, please. And I welcome Dr. Deepthi Mishra. She's a surgical oncologist from Thangam Cancer Center, Namakkal, and she's done her MBBS from Odisha, MS General Surgery from KGMU Lucknow, and MCS Surgical Oncology from none other than TMH Mumbai. And her special interest is in robotic and laparoscopic surgery, complex surgical oncology, breast cancer, and peritoneal surface malignancies. Welcome, madam. Next slide, please. And I'd like to call upon my dear friend, Dr. Gomati, Professor of Obstetrics and Gynecology at Government Kilpauk Medical College. She was a student of MMC, both UG and PG, and she headed the Department of OG at Tuticorin Medical College for 3 years. Field of interest is obstetrics, intensive care, and laparoscopic surgery. And okay, welcome you all for this panel. Yeah. So just a minute, I will share my screen. Is my screen visible?
Yes.
Yeah.
You need to
Slideshow mode.
Right,
Yeah,
sure.
this is fine.
Yes.
Yeah. So now we've had several, most of the controversies being already talked upon in the previous sessions. So I'll just try to move ahead and cover those things which have not been covered. So we'll move on to the first case. The 42-year-old multiparous woman who presented with heavy menstrual bleeding. Ultrasound showed multiple uterine fibroids and an endometrial thickness of 16 millimeter. She's obese. She has no comorbids, no positive family history. A Pipple endometrial biopsy showed a disordered proliferative endometrium. Of late, this has become a very favorite of pathologists. A lot of time we are getting this report of disordered proliferative endometrium. Pap smear was normal. Now that is the stage. And question is, this has already been dealt with by Dr. Gurumurthy. So I'll ask Dr. Gomati. Now we know that the cutoff for endometrial cancer for postmenopausal women with bleeding is 4 or 5 millimeter, and for an asymptomatic postmenopausal woman was 11 millimeter. Dr. Gurumurthy said that. But do we have a cutoff for premenopausal women who presents with heavy menstrual bleeding? Dr. Gomati, can you please take that?
Yeah, cutoff of the postmenopausal bleeding. Yeah, already Dr. Gurumurthy has said it is 4 millimeter because the sensitivity is 98%. But if the patient complains of bleeding, after we can do cutoff as 4 millimeter itself, because Pipple is a very simple office procedure. So it's nothing wrong keeping it as 4 millimeter or 5 millimeter. In a premenopausal woman, we can keep it as a 10 millimeter. Especially if it should, but for the uniformity, we have to do it between the 8th day to 12th day of the menstrual cycle. And so I feel it is 10 mm, but not so in all the patient. The patient is a high risk factors like nulliparous women, familial history, or obese patient. Even if the thickness is less than 10 millimeter, like 8 and 9, and if it's not responding to medical management, I will go ahead with Pipple biopsy.
Yeah. See, that's rightly said is that we do not have an exact cutoff like for a postmenopausal woman, because in a premenopausal setup, it keeps changing in the proliferative phase and secretory phase. It goes up and down. So you actually have to use your own discretion, because ultrasound, somebody does an ultrasound, they just give a report of thickened endometrium. You do not have a cutoff, general cutoff in a premenopausal women. You use your discretion. And if you think that the patient has got a family history, if she's obese, gives history of PCO, or if there is heterogeneous areas within the endometrium, then you go ahead and do a biopsy for these women. You actually don't have a number cutoff for a premenopausal women. But then they've done, already this has been discussed, is Pipple the right first line investigation for any patient who comes with heavy menstrual bleeding, if it's possible? Dr. Gomati again.
What? Pardon?
Yeah. Is Pipple the right investigation to do for?
Pipple is first line of investigation. It is the right choice because it is both sensitive and specificity is very high. Only if the specimen is very negative for the histopathological examination of the lesion is focal, or if you diagnose polyp, then it won't be positive. In that case, we have to go in for dilatation and curettage or hysteroscopy, whatever is necessary, because hysteroscopy is also therapeutic.
Yeah, so hysteroscopy, that is this point we already discussed just prior. When would you do a hysteroscopy in patients with heavy menstrual bleeding or a postmenopausal bleeding? So that is when your Pipple is non-diagnostic, or if you're not able to do, or if you have a recurrent bleeding. So then when you're going to do a DNC, it's always better to combine it with a hysteroscopy, because you do not miss any focal lesion. So is it safe to do a hysteroscopy in a suspected CA endometrium? So it's the same thing. Can you just tell your views on safety of hysteroscopy in a suspected CA endometrium?
As already you said, in cases of focal lesion, or when there is a polyp, obviously the dilatation curettage, the specimen won't be enough, and Pipple is always it's going to be negative. So if the patient is almost, if they are old, if they are going to do definitive surgery, definitely we can do hysteroscopy. because if it's going to disseminate by peritoneal cytology, anyway, they are going to do definitive surgery. But the problem comes in a conservative surgery. I don't know, but we have to say in a conservative surgery in a young woman who has stage 1A, and we are going to proceed with medical management for completion of the childbearing age group. I don't know whether it's going to alter the overall survival rate if you are going to leak the uterus for 2 more years till she completes the childbearing age. Whether this peritoneal cytology positive, it's going to affect the overall survival rate, you have to tell Kavita. Yes.
Yeah, so now several meta-analyses have shown that in low-risk women, because fertility preservation, we are planning only for low-risk patients. We're not doing that for high-risk women. So in low-risk patients, only positive peritoneal cytology is not going to alter the prognosis. So I guess hysteroscopy definitely can be done if people is going to be non-diagnostic, and then you are again going into for another endometrial biopsy procedure, you must definitely do a hysteroscopy and biopsy. So for coming back to this case,
just 1 minute, if I can add on. Actually,
yeah, please, Dr. Balaji.
The cutoff which is mentioned for the proliferative phase and the secretory phase, there were a couple of trials, and one from, I think, from Korea, which they had mentioned, 8 millimeter in the secretory phase, and in the proliferative phase is 16 millimeter as the cutoff. So that we can have the tentative cutoff just to give a number. Of course, as you rightly said, it's clinical judgment which is going to matter more in a premenopausal woman.
Okay. Thank you, Dr. Balaji. Okay, so for this particular patient, no other evaluation was done. Hysterectomy, because she was 42, a TAH with bilateral salpingectomy was done. Ovaries were preserved. So here, but a uterus was removed in toto. It was not morcellated, no screw was used. But unfortunately, the final histopathology turned out to be endometrioid adenocarcinoma, grade 1 with less than 50% myometrial invasion and LVSI negative. So now this is something that we see in our day-to-day practice. So I'd like to ask Dr. Balaji, now how do you think you're going to plan to manage her?
No, usually the thing is, like, we tell them about the risk of, we basically tell them that whenever we have a diagnosis of carcinoma, the ideal thing is to completely stage a sentinel lymph node or some way to stage the nodes. In this particular patient, though, already the surgery is done, but all the features are low risk. Basically, there is no LVSI, no deep myometrial invasion, no high risk features are there. So even NCCN mentions this select group as a group where we can selectively observe them after understanding the due risk that, it is not a complete staging. The other option which is also mentioned is, of course, you can go for, either adjuvant RT, that is one option, or complete the surgical staging and do it. All three can be given as options, but I will be okay to observe this lady as well.
So would you do an imaging for her?
Yes,
so what
scenario, like, it needs to be an MRI of the pelvis or a CT scan of the pelvis to look for the nodes, possibly even a PET and all that. And then if everything else is negative, that is when I'm talking about a scenario where we can observe her.
Yeah.
Can
so
I add
Dr.
something?
Deepti, yeah, please. I'm going to ask you. Yeah, please.
Yeah. So the thing is, I'll be more comfortable. First thing, I would like to just review the histopathology. Exactly. Because always as you told, this is a day-to-day scenario, and the specimen comes like that. It's better to take another review of the things, and then we have to do an imaging, and definitely we have discussed about that MRI is good one, but when we see that nothing has been done, and one is investigation which is commonly can be done also is CECT abdomen, which will cover the other areas also. So we have to do the imaging, and then whatever Dr. Balaji was telling. So I would like to review it and then proceed with the imaging and further.
Yeah. So would you prefer to do a PET CT in this case, or in any case of CA endometrium? When would you do a PET CT at all, or in any scenario? Dr. Deepti, you can take.
Yeah. So in this case particular, I don't think so PET CT should be done, because all are it's a low risk category. Definitely in a recurrent setting and an advanced cancer high risk, if somebody recurs, then on those settings, PET CT can be additional investigation. It is not the modality of choice per se for the CA endometrium.
Yeah, I think Dr. Balaji, you'll agree, or you differ?
No, nothing to differ. I mean, we all know that MRI is the modality of choice for the pelvis. For the abdomen is going to be the CT. So it's actually complementary to each other. What we generally advise is an MRI of the pelvis and a CT of the abdomen and the retroperitoneum, because patients cannot lie for a long time. So that is what is done. Even routinely, as you say, definitely no PET CT as a routine. But in this particular scenario, why I would say that is because, sometimes you'll find some few nodes which are there, whether they have uptake or not. That is the reason why I suggested PET as an option. But I'm not saying, see, sometimes you'll get a low grade uptake, which may not really contribute as well.
Yeah,
But
so because this patient had surgery previously and you can have reactive nodes. Yeah.
so, but if we have a node with a very high uptake, then our decision is going to change. So that is why I said, because we may get just a node of around 1 to 1.5 centimeter size, which may be reactive, which may be actually malignant. But if we do a PET and it has got a high activity in this kind of a scenario, primary, no, primary or just anyway, we are going to do the staging. So that's fine. But in a sitting like this, when we are deciding on things, if the node is showing a high uptake, then my decision is going to change. I'm going to complete the staging definitely. So that is why I suggested the PET CT in this scenario.
Okay. So this particular case, it has to be discussed on a case to case, because the problem is here, the ovaries are also conserved, but then she fits into the criteria of conservation of ovaries. So supposing she was a case of, disease involving more than 50% of myometal invasion, or if she was a grade 3 disease, then what would you have done? Dr. Deepti?
Yeah, then definitely a scenario will change, and we have this. We know that the patient is under stage, and we have to take a call. The thing will go in that way, review, and then we have to do one imaging, and we have to counsel for the thorough, proper surgical staging for the stage.
Yeah, so definitely. So depending upon the histopathology, then you could decide on. Are you going to plan for observation, or you're going to give her vaginal brachytherapy or any other adjuvant therapy because the staging was not done for her properly, Dr. Balaji?
As I already mentioned, ma'am, all three are options here. I would discuss all the options with her and then take a call. With regard to ovarian preservation, though, there is actually a big meta-analysis which has come, which showed that ovarian preservation, contrary to what we think, actually has an improved survival in patients with endometrial cancer. As vis-a-vis, they actually did a comparison where they did ovarian preservation and this one. They have given a very specific age group. It's basically for this kind of group where you have a grade 1 endometrioid cancer, and obviously for younger patients, the definition cutoff they have is 50 years. So when they have that, and what they say is we all suggest the synchronous primaries, the incidence of metastasis is 5%, but in practice, what they have mentioned is if the ovaries are normal on imaging and on intraoperative evaluation, the chance of having ovarian metastasis is less than 1%. So for that 1%, whether we need to go and take out the ovaries, especially in a lady like this, I wouldn't be thinking about it. If Deepti is very right, we have to actually go back, go and look at the, the data on the histology, because, I just put it as the gospel scenario, what you have given, everything else is matching. But yes, right. If it comes from outside, then we'll always review the slides, make sure the grade is fine. Everything else is matching, the imaging is negative, then I'll be happy to observe her as well. I will be happy to preserve the ovaries as well.
So we have a particular category of patients who will ideally benefit from restaging. It's not that when you get a diagnosis of endometrial cancer, immediately we suggest restaging for all these patients. So this particular thing, I took it from the European guidelines, the ESMO, European Society of Pathology guidelines. The first one is the low risk. The second is intermediate, and the third is high intermediate risk. Now, I somehow personally feel the European guidelines are much more, they have much more clarity than the NCCN, and they've incorporated the molecular classification as well with regards to adjuvant therapy. So I kind of prefer, that's a personal preference. So these three categories, now which one of these do you think who will ideally benefit from restaging? Yeah, Dr. Deepti?
Except your low risk, I'll go for the restaging. As an oncologist, definitely I'll go towards the restaging for all rest of two.
For both the for Dr. Balaji?
Yeah, I would agree. See, because the highest benefit will be for the third group where you have high grade, deep, or grade 2 or LVSI positive. But then, when we as oncologists like to do a little bit of over treatment rather than this. We have changed our philosophy, but then we like to be playing it safe still because we cannot afford to make mistakes. So I would agree with Deepti completely. If it is completely, because the scenario which you told was all low risk. So that is a very clear answer. If anything was there, deep invasion or LVSI or high grade or anything, any of the risk factors were there, I would agree and say that, probably it is better to go for a restaging rather than observer.
Yeah. So
one more addition, I just what we were discussing. Actually, this is we are in a panel. That's why we are discussing one. But even if there is a 5% risk of getting an ovarian malignancy in due course, I think so we would rather save that lady from getting that ovarian malignancy. So being an oncologist,
I think we have to discuss that with the patient, madam. Patient must be able to make the decision. You can explain that. Now, Dr. Gurumati said you have a 3% risk, and then you must, if the patient wants to take the risk, I think in our group of patients, they generally would not prefer to take the risk. But then ideally speaking, you can involve the patient in your decision making. So yes, as you rightly put, the highest benefit is for the high intermediate risk category, because if these patients, the risk of node positive is going to be quite high in this group. And if the patients are node positive, then you will have to add them adjuvant chemotherapy as well, along with, radiation. So that, because otherwise you may avoid, you have to give chemotherapy. So the adjuvant therapy is going to change based on that. So that is the reason where the high intermediate risk category is the ones who will really benefit from restaging. So we'll move on to the second case.
One thing, Kavita.
Yeah. Yes.
These patients, generally what we have seen in practice, if the patient has some sort of a fibroid and if there is a query, generally what I have seen is these patients come out with an MRI which should have been done prior to surgery. So when you had the discussion, I heard Deepti and Balaji telling about post-op MRI. So keep in mind about the pre-op investigation which has been done already. So those two things can be compared if at all you are going to plan. And the nodes and other things, whatever we were talking, those things will be helpful for comparison purposes. Many a time what I have seen is if there is a fibroid, we generally have seen people getting a MRI done pre-operatively. And if there is a suspicion of all these things, it is usually done. That's what I thought I'll just
Yeah, that's right, sir. So we can review the MRI as well, as you said, along with your histopathology. Yes. So shall we, we'll move on to the second case. Now this lady, postmenopausal 55-year-old, had presented with a postmenopausal bleeding. Her ET was 12 mm, obviously above the cutoff. Endometrial biopsy showed endometrioid intraepithelial neoplasia, EIN. Again, a very common scenario. Now, the question to Dr. Gomuthi. Now, is EIN the same as atypical endometrial hyperplasia, or is it different?
Yeah, it's almost EIN, the same method of the WHO classification, hyperplasia. But some studies says EIN is more accurate in predicting the disease. But whatever it is, we have to consider both as a precancerous lesion, and we have to go ahead, monitor the patient if you are going to give conservative treatment for the early case, and definitive treatment if necessary for both the patients. We have to consider this as the same only.
Same only. Dr. Balaji or Dr. Deepti, would you like to add anything, or?
Practically, according to treatment, these are same.
Yes.
Management wise.
Yeah. So WHO, when they, Yes, Dr. Balaji.
AEH is basically the WHO 2014 thing, and EIN is the other group which has.
So WHO third edition, they actually said EIN was different from atypical hyperplasia, and they had different diagnostic criteria and all. In the fourth and fifth edition, they have merged both together as synonyms. So it is actually EIN is same as atypical endometrial hyperplasia. And we've already seen this. Does it have a risk of harboring associated concurrent invasive carcinoma? Yes, up to 40%, you can have a concurrent invasive carcinoma. So how are you going to manage this patient, Dr. Balaji?
If I want to give a practical answer, then likely we will end up doing a hysterectomy for this patient, and then we'll do the evaluation, make sure that all the pathology and everything is all right. The same way, review of imaging, everything, and if everything concurs.
No, imaging has not been done for her. So only a postmenopausal bleeding, biopsy, EIN. So next step.
An MRI, and we'll do an MRI of the pelvis and the screening of the abdomen as well. Ensure that there is no other disease, or if there is something infiltrating into the myometrium. All these are things like whatever we do routinely for an endometrial staging, all that we'll do, and then take a decision. If the disease does not, if there is nothing which is seen, or there is something only seen in the endometrial lining, not even with any kind of invasion, then it is likely to concur with the diagnosis of an EIN, or probably non-invasive endometrial carcinoma, or rather non-muscle invasive endometrial carcinoma. That is what we are likely to find. So in such cases, there is the management using a conservative therapy as well, which is available, which is in fact the recommendation which is given based on the guidelines. But in India, I think practically all of us, even the patients, will end up asking for a hysterectomy. That is what will be done for this patient.
Yeah, Dr. Deepti, anything you want to add?
Yeah, definitely. For this, because she's 55 and postmenopausal, so definitely the surgery will be first choice for her. If she's not adamant on any.
How much surgery? Now you've done an MRI. There is only endometrial thickening, no evidence of any myometrial invasion. Now, how much of surgery will you do? Will you just stop off with a hysterectomy, or will you do the?
Kavita, I want to add one thing.
Yes, sir. Yes, sir.
It's a postmenopausal lady.
Yes, sir.
Please, it's nothing wrong in getting a mammogram also. When you're proceeding with investigation,
Yes, sir.
please get a mammogram.
Yes, sir.
So endometrial cancer, hyperplasias, in the long run, patients are prone for these breast cancers. So keep in mind about a mammogram by which you go for a screening, you're getting the breast screen, and this is going to be helpful in the post follow period for the patient. So
Yes,
keep that in mind also, always.
Yes, sir.
Breast should be assessed. A clinical examination should be done. A mammogram should also be done.
Okay. So it's, yes, sir, definitely point taken. So what would be your extent of surgery? No myometrial invasion, whether will you stop short with a hysterectomy or will you do the nodes as well? Dr. Deepti?
Per se, if we go by this diagnosis, there is no recommendation to go for the lymph node dissection. So ideally hysterectomy with bilateral salpingo-oophorectomy, we should go. That is the minimal surgery we need to do here. But the thing is, what few articles which I was seeing, the people have started doing sentinel lymph node biopsies for these EIN. Because again, the frozen, because it is not that it will not, it can tell on the on-table frozen, suppose we do, it can tell about the high grade scenarios. But if it is a low grade, we cannot differentiate. So there are some studies, I don't know what is the current evidence, whether we should go or not, but definitely minimal is for hysterectomy along with the bilateral salpingo-oophorectomy.
Yes, definitely. Practically, we see this day in and day out. It's a very common scenario that we see because I am associated with a gynec hospital. So this is something that I see in day-to-day practice. And what happens is, like for more than 40% in our setup, in our series, 50% of them are upgraded in a post-op histopathology to an endometrial cancer, and 40 to 50% are myoinvasive. They are not superficially invasive cancers when you detect them. And we have a 10% high-grade disease, which are pre-operatively reported as endometrial cancer. They become grade 3 and even carcinosarcomas in post-operative diagnosis. This happens actually. So that is a problem. So we've stopped not doing the nodes for atypical endometrial hyperplasia. We definitely address the nodes because we do not have a setup for sentinel node biopsy. I go ahead and do, lymphadenectomy for these patients. But definitely, as you said, if you have a choice of a sentinel node biopsy, it must be carried out for an atypical endometrial hyperplasia because 50% is a very large number. So we do not want to be sorry, always rather better to be safe than sorry. So yes, Dr. Balaji.
We can still use, at your setup also, I think we can use quite safely methylene blue dye. You will have frozen section there that can be substituted. We don't need to use ICG. Even with
methylene blue, we did one study in Roypeta, sir. I hate that dye because one thing, either you do not get the dye or the entire pelvis becomes blue. It is like
because I've used it quite well. That's why I'm just giving it as a suggestion.
No, maybe I'll talk to you on regarding the actual technical aspect because
even with the 50% incidence of cancer, still we are grossly over treating 50%. We know that.
I know that is the problem. This is what is my personal experience.
Endometrial carcinoma, yes, definitely yes. But in EIH or something, if that is the diagnosis, if it's a pre-operative, it's a pre-cancer scenario we are having, I think we can definitely do a methylene blue dye with frozen section. That is
a problem.
What Kavita says is also true. What Balaji says is also acceptable. So it's a technical thing. So the injecting of the methylene blue is the whole game on that area. So now I think you need to progress.
Yeah. Okay, sir. Thank you. So I think we'll stop short with that case because I just wanted to bring up this, concurrent endometrial cancer and atypical endometrial hyperplasia. So the third case is 60-year-old woman presented with postmenopausal spotting. USG ET was 14 millimeter. PIPL was non-diagnostic. So hence a hysteroscopy was done, which showed a polyp, and a polypectomy was done. The histopathology of the polyp was reported as serous endometrial intraepithelial carcinoma, EIC, and the background endometrium was atrophic. So is this the same as a precursor lesion for endometrial cancer? Is this the same, similar to EIN? Is it similar to EIN? So Dr. Deepti, or is it different?
So the SCICs, rather we tell it is a pre-malignant and independently malignant. So that is not true for the EIN. So it is something more than EIN. We should not equate both the things. We have to deal with the SCIC with more aggressively. So
Yeah.
Yeah.
So this is not the same as EIN, though that it is intraepithelial it is an intraepithelial carcinoma as such, and its behavior is like a serous carcinoma. So it is very, very important that we manage them like a serous carcinoma. So how are we going to manage them, Dr. Balaji, this patient?
Yeah, there
What
is
would be
actually
your
one thing is like we do not have evidence for suggesting either way. But in general, what you and Dr. Deepti has said is absolutely true, ma'am. Like these are more aggressive than EANs, though it's intraepithelial, they are more aggressive. So we do the full staging, including an omental, biopsy or an omentectomy. We basically treat it like a serous endometrial cancer. We treat it like an ovarian cancer more rather than like an endometrial cancer. So that is how the staging procedure should be done, because even with the diagnosis of SCIC and nothing found on the uterine specimens, there have been incidents where there is, nodal metastasis, where there is peritoneal disease. All this has been anecdotal reports are there. Of course, we don't have any data because the incidence is quite low for this. So for that, like any other disease which has got a low incidence, we may not have consensus, but general dictum dictates that this is an aggressive tumor. So probably we'll deal with it in an aggressive fashion, like an ovarian serous carcinoma.
Exactly, sir. So that's how you have to deal with this. And what is more important is this usually arises on a polyp, on the background endometrium is atrophic. So if you do an endometrial biopsy, PIPL, fractional curettage, we are not going to get anything from this. This is exactly the reason why we need to go ahead and do a hysteroscopy when your initial PIPL biopsy is non-diagnostic. So you will be able to do a polypectomy. It will not come out on a fractional, generally doesn't come out on a fractional curettage specimen. Now, another very controversial point, I put. Yes,
this is again one point I would like to stress again what Dr. Kavita said initially and now what she has made again. Many people, especially those who are from a non-gynec background, do not understand the importance of hysteroscopy where it should be done. If there is one single indication, I would say is what Dr. Kavita has already mentioned. Whenever you have a polyp-like lesion, that is something. Many people will say, okay, I've done a PIPL, I've done a DNC, both are negative, so it's going to be fine. No, it is not. You will get polyps which cannot be picked up by both, which will actually harbor a malignancy as well. And that is where we have to think in one line, if you want to know, that is the main indication for hysteroscopy. Just wanted to stress it, ma'am.
Yeah, that's correct. Yes, sir. So another because we are dealing with all serous cancers, I just wanted to touch upon another very controversial area in serous cancer. We know that serous cancers are aggressive. The chances of having extrauterine spread is going to be 40 to 50% if you thoroughly stage them. So obviously they will be like stage 3 or above, and you are going to give them adjuvant therapy. But if you have a patient who is staged well and she is a stage 1 serous cancer, now what is the adjuvant you will plan for them? Dr. Deepti, Dr. Balaji, both of you can give your opinions on it.
So again, it is already we know this is a high risk category serous carcinoma. So there is again what you already mentioned. There's a controversial thing for stage 1A without myometrial invasion. The thing is the 1B we know that we have to treat with the systemic therapy. And here there are some recommendation is only for the vaginal plus minus systemic therapy. So again, we have to take a call depending on other risk factor and explaining the patient if they are agreeing. But the most of the time, we should go towards the more treatment covering with the systemic therapy along with the radiation.
Definitely with myometrial invasion, we are going to add adjuvant chemotherapy with or without brachytherapy, vaginal brachy maybe. If the patient has got a peritoneal cytology positive, even if she is 1A, then again, you are going to give them adjuvant chemotherapy. The only small subset is if you have a lesion confined to a polyp with no degree of myometrial invasion. That is some setup that you probably will have to discuss on a case-to-case basis, and you may observe the patient. So that is something that is because totally very underrepresented in all the trials, and you will have to take a decision on a case-to-case basis, I guess. Am I okay with the answer? Both of you agree?
Yes.
Yes.
Yeah.
Yes.
Probably I'll just say that in what Deepti said, we'll give both radiation. We will advise strongly for chemotherapy as well.
Yeah, definitely. Okay.
One word of caution.
Yes,
when
sir.
such reports comes post-op pathology, please involve the radiotherapist and the medical oncologist.
Obviously.
As surgeons, what happens is we are more confined to that of surgery. We tend to miss the latest things which are coming up in many number of radiation therapy trials or medical oncology trials, and some point might be there which might be useful for us. So involve it as a multidisciplinary. That will be the best.
I asked you, sir, when you said the panelists whether there was any medical oncologist or radiation. You said only surgeon. So they are surrogates for radiation and medical oncologist here. But definitely these patients will go through a tumor board before you come up with a final decision.
100%. I think everybody with the diagnosis of cancer should have a tumor board. just to, involve people and make sure that we get the latest treatments available.
So can we move on to the next case? We'll just try and see only if this case, please let me know if the time is going to be up. So 33-year-old lady married for 5 years, nulliparous, she's desirous of fertility, complains of heavy menstrual bleeding for 4 months. She has been having irregular cycles always, history of PCO, and she's a known hypothyroid. Her maternal grandmother had CA breast. Now her ultrasound showed bulky uterus, endometrial thickness is 23 millimeter, and she had bilateral PCO. An endometrial biopsy evaluation showed a well-differentiated endometrioid adenocarcinoma. Now this scenario we are seeing more and more these days. Now in a very, very high incidence of endometrial cancer in women who are desirous of fertility. Now, when can you consider preservation of fertility in CA endometrium, and what investigations would you prefer for her? Dr. Deepti, do you take that question?
So again, this particular scenario, first I'll keep the thing that we should, the patient should be the one who should understand the risk associated. First thing, I'll keep it like that, because when we start explaining it, they should understand the risk associated. Then it is very early tumor. It is 1A, grade 1, grade 2, confined, no invasion, confirm in MRI. Then only we can give an option for this thing. Along with that, in this type of patient, I think so, we should always work up the patient regarding the infertility status, whether they are having any risk of getting pregnant, any chances of getting pregnant, when even if we are conserving we are giving any conservative treatment. So I would like to assess towards the infertility point, then investigation and the counseling.
Definitely, ma'am. Yeah. So we need to involve the fertility specialist right away. That is a point well taken. So investigation of choice obviously is an MRI. You can do either a contrast enhanced MRI or a diffusion weighted. The thing, what are the criteria basically? You said low grade. There has to be no myometrial invasion. So currently fertility preservation is offered to only low grade, that to grade 1. Low grade includes grade 1 and grade 2. There are very few studies involving grade 2 women. So grade 1, no myometrial invasion are the ones, and then no family history. We must, young girls, we must rule out Lynch syndrome as well. So these are the patients who would, and obviously no evidence of extrauterine disease. Those are the patients who would consider for fertility preservation. So what are the options available and how do you treat them? Dr. Balaji,
Yeah, so as far as the treatment option is concerned, ma'am, here is where we'll again go for a hysteroscopic resection to ensure that completely whatever visible tumor is there, and probably, take out the entire uterine cavity. And after that, we put them on progesterones, which is the preferred modality. It can be an intrauterine device, it can be orals or anything. So then we give the treatment and the NCC, and I don't have a personal experience, but what I've read up is such patients, they are put on treatment for around 3 to 6 months. And every 3 months, we have to go back and do an endometrial biopsy, either hysteroscopic or a DNC. And every 3 months, the biopsy should be negative. By 6 months, the biopsy should be negative. The NCCN guideline goes like this. So if at 6 months, there is a residual carcinoma, then they straight away go into the staging pathway. We have to do definitive surgery. There is no role of, fertility preservation. If they continue to be, cancer-free at that point of time, or they become cancer-free at that point of time, then we can, push them towards assisted reproduction and all that, complete the family, and then complete the staging. That is the recommendation we just give.
Dr. Kavita, there is a comment from Dr. Shivakumar saying that definitely these patients need to be counseled, that fertility preservation is not the standard of care, even if it fits all the criteria, and then the patient should be, how do you want to take that?
Sir, they have to be counseled. We get a written consent, but the problem is, at the end of treatment, if they do not conceive, they don't come back, sir. That is a problem we face. I don't know what to do. I have a couple of patients who regressed following therapy and sent them for ART, but then to keep them under follow-up, it becomes very difficult, to have a child is so ingrained in their minds. That is the problem we practically face in our country, even though they know exactly what is. We tell them multiple counseling sessions, but still that is the problem we face practically on a day-to-day basis.
Yeah, I have also experience of treating only 5 cases for And correctly, none of them have come ever after that counseling and 3 months of treatment. Never they came back.
No, so madam, I cannot blame all my patients. A few of them are like that. I've had one conception also. One girl also delivered recently. So it is possible that they can come. Depends on patient mindset. So what is the treatment that you would prefer of all these given? What do you usually give for them? High dose progesterone, LNG-IUS. Yeah, Dr. Deep.
Yeah. So the thing is, usually earlier, this is again along with my gynecologist, I started treating with them because the fertility was an issue. So medroxyprogesterone, and rather in higher doses, to 200 to 600, depending on how they're responding. And we tried with LNG-IUS also, but the problem with this, when you take them for the hysteroscopic examination 3 to 6 months each time, we have to take out the LNG and do that examination. That was a practical problem. Otherwise, there is both pros and cons for both, because this is taking a tablet daily and versus keeping a device is easy thing to do. So I think so both are the options. And few studies have shown that LNG is better than high progesterone, and some other are telling the reverse way. So any of these can be taken up.
Yeah.
Kavita, we have a fertility specialist in our panel.
I'm going to ask her. Dr. Bhuvana, I'd like to get your opinion on hysteroscopic resection, and then further, if you're going to send the patient for ART to you, how is it going to match? Is it okay for you if you had a previous hysteroscopic resection and the pregnancy? Because the whole idea is to get her pregnant later.
Yes.
What do you think?
Yeah, this again, one or two things I would like to add, even for the few questions in the beginning, like investigations, when we see that not only MRI to rule out this invasion and other things, again, the other partners, everything, we should really counsel that whether they really want that fertility and whether they are eligible or not. So everybody wants a fertility thing, but really they are having eligibility and whether everything is all right or not. At the end of the day, if they have some other problem, even if you do all this conservative, they may not go for fertility treatment and they may not succeed. Second thing is again, like treatment options when we are doing what we are saying is even with the Mirena, like LNG-IUCD, we can still do a PIPL. There are some studies where we can still go ahead and
practically we've done, madam. With the LNG-IUS, you can do a PIPL biopsy.
Yeah, we can do, and when two sittings it is coming negative, then we can advise them to go for pregnancy. And hysteroscopy, I would prefer to do myself because I know we have seen patients after doing it with a biopsy report coming for the fertility treatment, but it is better when we see them, not only this, whether the cavity size, ostia, and so many things, like even the cervical length and internal laws, everything matters here, so that it is not only on the cancer aspect, as a fertility aspect, it is better if we do the hysteroscopy, we may get additional benefit. And also same time, like resection, generally curettage is done, and then followed by we can put LNG-IUS along with the medroxyprogesterone or something, because a lot of studies have said along with the LNG-IUS with the MPA as a good response.
Yes, madam, definitely. See, what we felt is like only LNG-IUS, practically speaking, hasn't worked in whatever small series that I've got. So usually what we do is like, and we do not do a hysteroscopic resection because of a small risk of Asherman syndrome occurring later on. So the whole purpose is defeated. We know that when you do a hysteroscopic resection, the cancer becoming R0 is going to be higher, but then the Asherman syndrome risk
missing
increases.
of cancer tissues.
So we do not do a hysteroscopic resection. We do a complete DNC, and then we put them on LNG-IUS and then top up with an oral progesterone. Start them with an oral megestrol. Just start them with 160 milligram per day, and then see 3 months later. Now, at 3 months later, when we do a PIPL, if it has come down to atypical hyperplasia, or if it's just endometrial hyperplasia, we continue with the same dose. If it's the same, when then we increase the dose to 320 milligram, most of them regress by 6 months. Some of them require just focus of EIN comes like in 6 month biopsy. Then we continue it for 3 more months, total 9 months. A lot of them, they go in for regression, and then we send them for, the infertility specialist for ART. So, Dr. Bhuvana, what are the challenges in ART for these patients. We've had them on long-term progesterone, very high dose progesterone, possibly with hysteroscopic resection. So what is the problem you will face when you're doing an ART for these patients?
So these patients, when they come back with after a long progesterone, two things are there. One is the recovery. Sometimes the response takes more doses of injections. And again, we see endometrium being very thin, and sometimes we won't be able to. Again, we have to start something like estrogen or something, HRT, to build up that endometrium to get the pregnancy. Another thing is already they are actually OHS or PCO patient. Most of the patients are a PCOD, obesity, and with the metabolic disorders. And again, that becomes as a challenge, and hyperstimulation is another challenge we see. But basically, because of the resection and this LNG IUS, when we use that, endometrium becomes very atrophic. That is a major challenge.
That is a major problem. And the problem is you're very, not very happy to start them on estrogen. So most of the time you end up freezing the embryos and then wait for a natural course. Wait for
the time to develop the endometrium.
To develop, and then you go and do a frozen embryo transfer. This is what I've been seeing for a few of my patients. You're not able to do a direct embryo transfer. You freeze the embryos, keep it like that, and then allow the endometrium to develop, because we're a little scared to start them on estrogen. So then wait for the endometrium to build up and then do a frozen ET. So this has been dealt with. So
one more thing, we can ask the patient, their embryos can be freezed and they can go for surrogacy, and we can she can proceed with definitive treatment. She can go for definitive treatment immediately instead of all these complications. That is always better, I feel.
It's not that easy to get now with a new ART law. Again, the surrogacy becomes very tough.
No, for these cases for endometrial cancer, I think it is advisable.
Yes, that is what about the counseling. Like we always have, even in the beginning, we should tell if they are preferring to go for surrogacy, we don't need to go for so much. We just have to put them on long-term treatment and LNG, and then they can have a follow-up. Only because they want to conceive themselves, then we have to take all these steps. So otherwise, it is very difficult. And actually, these patients always have irregular cycles. Even if you don't, you do an embryo frozen, and then you will be waiting for the endometrium to come. Again, they'll become irregular cycles. Then we don't know how to prime them. Then again, the exposure and increased chances are there. So endometrial becomes more. Again, we have to go on curette. So that dilemma always comes. So at that point, we have to talk about definitely a surrogacy. But that option, the patient has
even if the patient is, if she's on treatment also, every 3 months once we need, if she's not pregnant, we need to keep her check on her endometrium. We have to do a people biopsy, make sure that she is not progressed again, because you always have a recurrence risk. Yes, Dr. Deepti, you wanted to say something?
Yeah, just I wanted to ask Bhuvneshwari ma'am that the stimulation protocols and all those things, how does it differ from a regular patient you take for the ART for these particular patients?
No, ma'am, a stimulation protocol, we can still do that. Only difference is here, like we don't need to wait from the diagnosis, we can just start the stimulation like random start. Nowadays, it is randomly used everywhere. Even in other poor ovarian reserve, we start whenever they come, we can start. So that is there. Again, thing is progesterone, when they are on medroxyprogesterone, even the low dose, with that, there are dual stimulations are done. Nowadays, recently, we have a lot of different protocols where even if they are on medroxyprogesterone, if they are on low dose, still we can stimulate. Again, to reduce the estrogen level, we always, like oncofertility, we give the letrozole to keep the estrogen under control. So those are the only few modifications we can do instead of conventional, where we only give a gonadotropins like FSH, LH continuously and then take them. Here we can start with the aromatase inhibitors, where they keep the estrogen under control, and then you add on gonadotropin so that the protection is there.
Dr. Kavita, there are two questions.
Yes, sir. What?
One is by Dr. Fanny Raj. She is asking the incidence of peritoneal dissemination after hysteroscopy. And another interesting suggestion by Dr. Shivakumar is, because he is very much interested in uterus transplant for these patients.
I think Dr. Bhuvneshwari will be able to, because she's in the center where
transplant center. That's why.
Transplant, so she can take that question.
So that peritoneal dissemination, as we said, that low pressure, when we maintain, then it will be reduced, but we can't really say how much pressure and like when it is going to spread or not, we don't know. But the uterine transplant, these cases, again, ethical concerns we have to see, because these patients are already on the verge of it. We are going to put the normal uterus also here. Again, they are getting exposed to the same kind of risk. So that is another point. I don't think this patient will go for a uterine transplant because that is, I don't think it is.
It is actually not mandated. The uterine transplants are basically done for Rokitansky syndrome,
Patient
where
for
they
MRKH or Mullerian anomalies is more proper, or a hysterectomy done for PPH, and those patients again we can still consider. I think this patient life is more important.
Yeah, exactly.
And Kavita, I have a question. Suppose if she is becoming pregnant and we cannot do biopsy for 10 months.
Yeah,
what
we
is the
can.
percentage
We don't do anything. We don't do anything during pregnancy. This pregnancy is already loaded with progesterone, so it is protective, and we consider that as safety.
So what is the progression after complete remission after 10 months? Any
No, you have 50% chance of recurrence. 50% it will recur. So that is why we do, this is only a temporary measure. And at the end of childbearing, we definitely suggest hysterectomy. But now there are some studies which say that if the patient wants to have another child, because this has been some 4 or 5 years since all this has been happening. Now patients have been started putting on maintenance therapy as well. Supposing after delivery, she wants to have, now she decides she wants to have one more child. Then there are some people who put them on again maintenance therapy, again keep doing endometrial biopsies. All these few reports are established now. But now, as of now, at the end of childbearing, we suggest hysterectomy for them.
Dr.
Because
Kavita,
the recurrence is very high.
Okay. During pregnancy, is there any chance of recurrence during pregnancy?
No, we do not know, but it is something that we do not know. But ideally speaking, that is not the time frame for recurrence. Usually it takes some 2 to 3 years for them to become, by then if she conceives, it's okay. Because before pregnancy, every 3 months you are doing an endometrial biopsy. Now, if she recurs, you're not going to allow her to become pregnant before pregnancy. You have only those 10 months. 10 months or maybe 1 year, 1.5 years. That time frame, generally, they do not recur.
Dr. Kavita, I need to interrupt here.
Yes, sir.
The time is
yes.
25. People will start shouting at me and Dr.
No problem. I think.
But the things are going on very interesting. Maybe another 5 minutes you can next time.
Yeah. So one question. Okay, Dr. Gomathi, do you think this endometrial cancer could have been prevented in this case? It's a known case of PCO. Irregular cycles always?
Known case of PCO, familial history, then she had thyroid problem. It could have been a Cowden disease or Lynch 2. We should have screened earlier itself a transvaginal ultrasonogram for the thickness, endometrial thickness. And
what is your say on patients for PCO? We have all, that's the commonest patient you get in your OPD, right? Irregular cycles, young girls. That is something that we see day in and day out. So what is your suggestion? What do you have? Because these patients are the ones who develop endometrial cancer at the earlier age. So it is very important that
it starts from the lifestyle modification, actually. Okay. So initially we have to tell them about the dieting, fitness, the BMI, she has to reduce her BMI, then and as well the transvaginal ultrasonogram screening for the endometrial thickness and progesterone supplementation in the later part of the cycle. All this it could have been
definitely because there are a lot of gynecologists in this forum. It's very important that these PCO women should not be left alone. You have to put them on either hormone therapy, put them on metformin, advise weight reduction, and always keep them in your background because they have this risk of developing. Because if you tell them that you will get cancer, then they will go reduce the weight. So that is the main thing. Okay, the last case, I'll just rush through this case because only 5 minutes are said. 61-year-old woman evaluated for postmenopausal bleeding, endometrial biopsy, grade 1 endometrioid carcinoma. This is a case like Dr. Suresh Venkatachalam sir said. MRI showed no myometrial invasion and she underwent staging. Final histopathology was a low-risk disease. Stage 1A, grade 1, superficial myometrial invasion, no LVSI, nodes negative. So obviously low-risk disease, she was not put on any adjuvant therapy. When she was kept on follow-up, 8 months later, she came with right ilia fossa pain. And on examination, vault was healthy. She did not have vault, anything to do with the vault. But on ultrasound showed possible omental thickening. A contrast CT confirmed multiple peritoneal and omental deposits. A guided biopsy showed serous carcinoma. Now she was P53 and PDL1 positive, ER/PR negative. Now to the oncologists in the forum, even Dr. Ayyappan sir can answer. Have you encountered similar situations in your practice, Dr. Deepthi, Dr. Balaji? Seemingly very low risk endometrial cancer presenting to you with distal metastasis on follow-up.
Only two in last 8 years I have seen only 2 patients like that.
Yes, it's a rare scenario, but then it can occur. So
Yeah, it can occur.
it can occur. So it is a, so
with the
what
fault-
can we do for that? You know, yes, Dr. Balaji, yes.
Go ahead, ma'am. No problem. Just that I've seen 3 patients, but all of them not with disseminated disease. I've seen vault relapses.
Yes,
Vault
vault
nodules
relapses is
happen
expected. We
irrespective
know
of-
that 5 to 10% of low risk endometrial cancers will recur in the vault, and then at the time of recurrence, you give them radiation. It's not going to alter the survival. So they are fine. We are not happy about that still, because the overall survival is not going to change. You pick them at the time of recurrence, it
In
is
this
okay.
particular scenario, I actually think this is a second cancer. I'm not thinking in terms of a recurrence, because initial diagnosis was endometrioid grade 1. What we have now is a serous carcinoma. So either she had some undiagnosed ovarian, or it could be a primary peritoneal.
It could
Because
be. The
we are-
problem is, sir, when you go ahead and do this, read about this molecular test. No, because when you see the situation, you are a little worried. Then you go and dig up all literature, right? So otherwise you don't do. So you find that 5% of this very, very seemingly low risk endometrial cancers can be P53 positive. So they can be a low grade endometrioid, but they can be P53 positive. So once they are P53 positive, they can behave in this kind of adverse situation. So it is only 5%, 95% it doesn't happen. But then this has kept me worrying. So now with all cases, it's only an IHC of 1,000 rupees. So I kind of go ahead and do a P53 IHC for all patients. It's not a recommendation.
Slightly contrary point of view as well. It was even discussed in some of the medical oncology forums. See, we generally say pole is a good prognostic tumor.
Yeah,
we don't need to do anything, but there are documented cases where pole has a poorer prognosis. In fact, even if you look at the molecular TCGA staging, pole, they will say some of them are higher grade. They don't say it's all low
exactly.
grade. We don't always match it with the type 1 endometrial cancer.
No, it doesn't match. That is what I'm telling you. It is a low
molecule
grade.
is not always the answer.
Yeah.
Yes,
So finally, so the idea is like, if this patient we had picked up earlier on P53 positive and a myometal invasion, you would have probably given her adjuvant chemotherapy at that stage as itself, right? So that is my question. So I'm just thinking out aloud. This is not a recommendation, but I'm just thinking out aloud, because with myometal invasion, a P53 positive disease, you are going to be more aggressive in your adjuvant therapy. So though the recommendations say that all your P53 molecular testing has to be done in all high grade disease, for me, I think it's the other way around. I do not want to miss a low risk disease who comes with a peritoneal recurrence later on. So I'm just thinking out aloud, and I just want to give your opinions on where exactly molecular testing will change current management, like this one. Any other situations?
Sir, I think every patient will go towards a molecular diagnosis. Already, pathologists are discussing, saying that, the role of, basically the routine pathology is just to establish the diagnosis and possibly a few risk factors. But then that is also kind of directly dependent only on the molecular pathology reports that we get based on the classification. We already have it for breast, for endometrium. It is now coming in, though it has not changed the management. But then, it is going to be part of the future treatment in every cancer, not just here, and probably for every disease, not just cancer. So completely agree with you. In the future,
yes, Dr. Deepti, yes.
The only thing is the cost. When the IHCs are okay with P53 and MMR, but the pole, I don't think so. That's why the only thing.
That is fine, madam, because pole, you're going to de-escalate.
Good rest. Yeah.
So, but to this kind of situations where you want to escalate treatment, I think IHCs are, they are not going to be very expensive. So you could try and do, and especially when you want to do a fertility preservation, it is very important that we have to do an MMR testing, IHC for those patients in endometrial biopsy. Now you cannot.
Don't get angry with me.
That's what, sir. This is my closing line. So I think when you're doing a fertility preservation, from now on, I think I've started doing an MMR IHC and a P53 as well, because I do not want to miss out on a high grade disease and offer them fertility preservation. So now slowly molecular testing has started to come to be useful in our clinical practice as well. Now I thank our esteemed panelists and Dr. Ayyappan sir for all the comments, and Dr. Sumathi Premanand madam, and thank you all. And anybody wants to give any closing remarks, you can.
I want to give one last comment,
Yes, sir, please.
We're all targeted on the uterus and the pelvis. The only word of caution for all of us is, whenever you are handling the pelvis, please look into the upper abdomen also. There might be some surprises. You should not be caught by those surprises in the post-op investigations when something happens with the pathology report. So always, whenever you're doing an open method, Put your hand in the upper abdomen. When you're on the laparoscopy, don't concentrate only on the pelvis. Just turn the scope towards the upper abdomen also. See what is happening in that. Though we have done all the investigations, sometimes you tend to miss. Just 1 minute of this caution will help you a lot. I think with that, maybe I should not be the person to end the thing. Is anybody wanting to say something?
Yeah,
thank
Yes, thanks, sir. Okay.
Okay, fine.
Gunda, you're muted. Yeah.
Yeah, okay, fine. Yeah, fine. So now coming to a conclusion, as an executive committee member of Oxy, I thank every one of you for having participated despite your busy schedule in this wonderful, focused and an educative webinar on the management of early uterine cancer. I take this opportunity to thank the President of TASO, Dr. Suresh Venkatachalam, the President of Oxy, Dr. Jairani Kamaraj, the secretaries and their respective teams for coming together for this synergistic program. We thank the esteemed chairpersons for your time, effort, and inputs. The speakers, panel moderator, and the panelists were very clear and precise in the treatment choices which are available to us, because this is a platform which is not just having oncologists, but it's also having a general practicing gynecologist too here. They were very clear and precise in the treatment choices, and they shared with well-researched academic expertise what best the patient in front of us could be offered and the need for the tumor board and not just one person in front of the patient. It was a delightful discussion, and we thank the Shield Pharma for providing us the virtual platform on this World Cancer Day. Special thanks to Chitrakala from Shield for the uninterrupted and very willing technical support and doing all the changes we were sitting on her head for. I must thank the pleasant Dr. Ayyappan for conceiving and delivering this program in association with Oxy. Thank you, delegates, for your enthusiasm to be with us till the end of the webinar and spending your precious evening on a screen. Wishing you all a great weekend. And if we could just switch on our cameras, whoever is here, we could take a photo. Chitrakala, would you do the honors? Are you here, Chitrakala? If we can simply switch on our cameras.
Yes, ma'am.
Yeah, can you take a photo, please?
Sure.